Good evening, everyone. I am Dr. Bharat Sabu, and it's a pleasure to invite you all to this metabolic update. This time, we are solely focusing on the injectable therapy because we all talk about oral anti-diabetic agents so much that we forget about injectables. And this time, we have thought about talking about injectables, insulin, as well as the newer molecule, which is the new kid in the block, GLP-1 analogs, how they work, what they work. And for this, we have an eminent panel of faculty because our focus is optimizing care. So we have hardcore clinicians as faculty because they are the one who have all the in-depth practical knowledge about what this injectable therapy is about and how to initiate and what to do with it. Because this is really a challenge for lot many to initiate a injectable therapy to a patient. We have esteemed panel of expert. I will give introduction of them as the time comes, but just a brief introduction. Dr. Manthan Sheth from Surat, Dr. Sandeep Suri from Hisar, Dr. Alok Modi from Thane, and Dr. Shambo Samrat Samajdar from Kolkata. These four eminent speakers, because these are all academicians, and they will be talking about what is there in and out about injectable therapy. You can post your questions in the chat box. And for housekeeping, we have disabled the videos of you, audios of you, but you can interact with all the delegates who are there. I can see around 82 have joined since now, and 82 are there, and they will increase because we have a registration of around 250 odd numbers. So all those are requested to post their questions, and I will be taking their questions to the esteemed faculties. Don't worry, all your questions would be answered and no questions would be left behind. In addition to these presentations, we have a discussion with the esteemed panelists for all practical insights about the injectable therapies. So before we begin, I want to just thank to our sponsors for the today's event, which is Cipla Pharmaceuticals and Walron Pharmaceuticals. These two have actually paved the way for this beautiful program because this was in pipeline since long, but we were seldom finding a company which is supporting injectable therapies apart from the routine ones. And I encourage all participants to actively engage most of this knowledge-based session because this is something, a unique kind of thing which is happening today. So let's start. And with this, I thank you all. Just a brief introduction about what we are going to do. I am the director for this program. I am based at Indore. And we have four speakers with us. Dr. Manthan Sheth would be talking about traversing the theory and practice of premix insulin, how and what to do. Then Dr. Alok Modi will talk about role of insulin in comprehensive diabetes care, where we are lacking actually. Dr. Shambo, with his pharmacology background, he will combine insulin and GLP-1 and he will tell us what are the synergistic benefits when we combine both these agents. And Dr. Sandeep Suri, being a hardcore clinician, will be talking about the patient-centric approaches in insulin and GLP-1 based therapies. So without taking much of a time, I will straightway introduce Dr. Manthan Sheth. Dr. Manthan Sheth is a diabetes specialist with a special interest in obesity and thyroid disorders. He is a member of various international and national bodies. He is actually author of The Beauty of Rhythmic Prayas 2017, and it was appreciated by Honorary Mayor of Surat for the same. He has a lot of accolades to his name. He is very active socially along with Lions Club and all those things. And over to you, Dr. Manthan Sheth, for your oration.
Thank you. Thank you so much for that nice introduction, Dr. Bharat Sabu, sir. Thank you so much.
Just
Mr. Pandey, can we please have slides?
Yeah, we are sharing your slide. Just
Thank you. Yeah. So at the outset, I would like to thank Prayas Diabetes Care and Dr. Bharat Sabu, sir, for having me over here. So I will be talking about the traversing the theory of and practice of premix insulin use. And this would be my case-based discussions. I will be sharing a couple of cases as well after the quick background on the same. So yeah, can we have the next slide? All right, fine. So basically that's disclaimer for us that it's basically only for the RMPs and the registered medical practitioners. Yeah, next slide. So yeah, I have a disclosure for today's. This talk is being sponsored by Cipla. Thank you so much for that. And yeah, we can quickly move to the talk. So I would be talking about the disease burden and overview, followed by the risk with uncontrolled postprandial blood glucose levels and importance of tailoring this insulin as per the patient need, from basal bolus to the premix and etc. Everything I would be covering today. From then we would be having the case studies, couple of case studies, and in between we would be having the clinical evidence on this premix insulins. Whether it would be a 25% out of 50, so that I would be taking in the case 1 and case 2. Yeah. So when we talk about the disease burden and the overview, yeah, Mr. Bandit, sorry, but you might have to just, I will disturb you to just uh, keep changing the slides. Yeah, thanks for that. So as a disease burden and the overview, we have, if you know, we are having almost more than 101 million people with diabetes. This is quite old data. If you see most recent data, it has almost increased 200 million in India itself, right? And we have almost 80% of the Indian diabetes patients, right? They are on the triple anti-hyperglycemic therapies, and still they are not able to achieve less than 7% of HbA1c, and that is the biggest concern that we have today. And the every 6% with diabetes in the world is an Indian, which has now going to be every fourth or every fourth person with diabetes in the world from India. So this is about the prevalence of the same. Next slide. When we talk about the uncontrolled glycemic levels in the Indian type 2 diabetes mellitus patients, you see that a lot of uncontrolled these things from the number of participations across the various studies from IDCI to DAB-CAP to Achieve to Present and Improve and ICMR India B, whether we have the mega trials of the number of participants by IDCI, that is 350,000. And if you see the HbA1c is almost 8.56 and plus or minus 1.8 from HbA1c to fasting to postprandial, we are seeing the lot of uncontrolled data over here as it is evident from this. So the major epidemiological, all these studies that have revealed that often we are seeing this kind of the uncontrolled glycemic levels. Next slide. So when we talk about this uncontrolled postprandial blood glucose, obviously all these things comes with the some sort of the complications, and we are aware about the macrovascular and the microvascular complications. Next slide. So in that complications, when we talk about all these, we have this macrovascular and the microvascular complications where we can see the carotid intima media thickness. From that, we may have this increased oxidative states or impaired LD diastolic dysfunctions, or you say the myocardial blood flow have been decreased, or let's say inflammatory markers have been increased, or risk of retinopathy has increased, and the risk of pancreatic cancer has even increased. So all these are being associated with the particularly the postprandial hyperglycemia. Next slide. Right. So these are the things that we see that more patients achieve HbA1c targets by adhering to the PPG targets than FPG the things FPG targets, right? So you see that in patients achieving FPG target are less than 100 mg per dl are hardly 64%. And if you see the patients achieving the postprandial less than 140 are somewhere around 94%, and 6% are not able to this. But in this, all these things, the biggest things that we are looking is this insufficient, this both the things are insufficient for achieving the target of less than 7%. Next slide. So the insulin in the Indian context, when we look at this, right? So in this way, we are having the insulin in Indian context. Next slide. Quickly. Yeah. So the biggest question that we have is, are we starting the insulin at the right time or not? Many times we see the insulins are not being initiated on the right time. We see that maybe there is more than 9% of the HbA1c. Sometimes we see in the practice that we are receiving the patients with 14, 15% of the HbA1c. Still, we see the reluctance from the Indian populations that they are not fine to initiate with the injectables. At that point of the time, we have to reiterate them about what is the right time of starting this insulin and what is the importance of the same to control and how good it can show the control to us, right? So the insulin therapy, when we initiate on the right time, right, and it definitely gives you the benefits and can reduce overall all your complications and etc. So the therapeutic inertia for the initiation of insulin therapy still exists. We all know this, and the timely initiation has potential for reducing the future risk of diabetes-related complications, as I said. Next slide. So when we look at these things, this is the premix BD dose and premix BD, the adults and the elderly and the fairly adult, right? So elderly, and these are like activities of daily living. This was the taken out, right? And over there, we see the preference as guided by the factors such as the high carb diet, high levels of postprandial glycemic excessions, and the delayed insulin initiation. We all are aware that India has almost become the capital for the capital of the carbohydrate, you can say. So almost all of our diet is very high in carbs, and that is the biggest concerns that we are seeing over here, right? So many times we see whether to use the twice daily dose of premix insulin in adult and elderly with no limitations of activity of daily living, and those data are there with us. Next slide. Over here is the RSS guidelines. I would not go deep into this in the interest of the time, but yeah, this is the guidelines that we have when we have to initiate the oral hypoglycemic drugs, and when we have to initiate the insulin therapy, and when the premix comes into the picture. We all are quite aware about the gold standard of basal and bolus, but then comes into the picture is the premix, and that's what basically I'm talking today. Next slide. So the importance of tailoring the insulin as per the patient need, right? So even that includes, next slide, that includes the basal, bolus, or let's say even the premix, right? So the considering the unique characteristics of type 2 diabetes mellitus in our Asian population especially, right? So we have to look after the high PPG exertion, high carb diet, beta cell dysfunction, average BMI, all these things. Next slide. Now, when I talk about the premix insulin's role in tailoring the insulin as per the patient need, right? So there comes the three things over here. And this is the most commonest things that we get the complaints from our patients, that when they are on the basal bolus or any sort of this therapy, they might have to puncture it for more times. And over here, with when we are having the premix insulin, that this simplifies the treatment regimen for us, right? So when we have these high PPG levels, right, so we can benefit this from the premix insulin. And why? It is because it combines the basal and prandial insulin components, and which ultimately helps the blood sugar spikes after meals. When we see this premix insulins in the patients, we see the reduced number of daily injections, and that offers them the simple regimen and the improving adherence with that. Compliance also increase with this, and especially for those who find this multiple injections little bit burdensome, right? So that is the biggest things that we can say that is the most beneficial for them. And the premix insulins, when that this simplifies this regimen, it follows by making it easier for them to manage the diabetes, especially with their variable meal schedules, who might have difficulty with complex regimen and etc. Right? So I will quickly move to the case studies. Two case studies I'm having, and first is about the tailoring insulin initiation with the low mix, and the another with the high one. Yeah. So this first case, when we are looking at this, the patient, Mr. CBZ, is there with the 60 years of the age. He is presented in the clinic with the inconsistent follow-up. And when we talk about his physical examinations, his weight is 72 kg with the BMI of 25.8. His vitals, BP is 130 by 84, and heartbeats are 78 beats per minute. When we talk about the labs of these patients, the A1C stands at 9.3% with the fasting 170 and the postprandial at 280. Renal function, when we see the create is 1.1 and eGFR is having 65, and this patient is quite a non-compliant, considering he is very inconsistent with the follow-up and presented with more than 9.3%. So why the subject this patient has visited over here, and reason for this visit, his dietary pattern, family history, and medication, all this. If you see the quickly on this reason for the visits, he's having the uncontrolled blood glucose levels, inconsistent with the follow-ups, willing to try injectable, but doesn't want the regimen to be complex. His family history, his father is having hypertension and type 2 diabetes at age of 59 years. His dietary pattern, predictable diet with heavy breakfast and dinner. Medication, he's on SGLT2 inhibitor, he's on DPP4, he's on metformin, he's on telmisartan, he's on chlorthalidone with having the And if DPP4 inhibitor, he is having sitagliptin 100 mg per day and dapagliflozin 10 mg per day. So we see that 3 drugs is already ongoing with this patient for the diabetes management. Next slide. So what to prefer and why to prefer premix or basal insulin, right? The gold standard is obviously going with the basal and bolus, but why to prefer the premix over here, right? And that is also why the low mix, right? So that's the question. So here is the things, the glycemic factors. So if we see this, the postprandial increment is more than 54 mg per dl, and the FPG, the fasting, and the HbA1c ratio is less than 20. This difference between bedtime and morning blood glucose value is more than 55 mg per dl. We should consider prandial insulin component through premix. So when we see the psychosocial factors in this, patient has limited literacy and has a simple and easy to understand regimen is needed for this patient, right? If simple and convenient options are needed for future intensification. Phase of life, adults at early or progression stage of disease and adult lipidation is need of simple therapy. And in the Indian reality, when we see this, if within the limited resources, simple and easy to explain insulin therapy is needed for initiation and intensification. Patient is on high carb diet, and if simple and convenient options are needed for future intensification. So these Indian realities we have to keep in mind over here. So what to prefer and why to prefer, as I said. So over here, choosing the premix or basal insulin and the consideration of the initiation. So what favors the premix? So more than 3 amp mole per liter, that is more than 54 mg. What is the postprandial increment, right? Is the patient likely to manage basal bolus therapy when intensification is needed? Whether a large carb intake is there at 1 or 2 meals, and whether the lifestyle is predictable, that is eating pattern or working hours, right? And the postprandial spike for this patient is somewhere around 110 mg per dl. And as we see all the experts right now with the Indian review, when postprandial spike is more than 54, premix insulin is the first choice for the insulin initiation. So over here, we would be recommending and we would be initiating the patient with the premix insulin such as Humalog Mix 25, which may improve control of both fasting and postprandial and convenience of initiation, titration, and intensification. When basal and bolus is there, it becomes little bit tough for the patients for that titration and the intensification, right? And over here, the patient is inconsistent with follow-up as well. So he needs a therapy with greater durability as well. So that favors the premix in this case. Next slide. So the clinical evidence that why we would go with Humalog Mix 25, the Lispro Mix 25 in type 2 diabetes mellitus patients with the uncontrolled DM and in the multiple oral anti-diabetic drugs, right? So here is it. So the durable trial was there, right, to assess the durability between basal versus Humalog Mix 25. Okay, and ultimately the results, the conclusion that we got is the greater durability of Humalog Mix 25 over glargine. The study design, study population, and intervention, I would not go into that in the interest of time, but quickly, if you see, 242 centers were there across 11 countries, right? The trial has 2091 insulin naive patients, and Mix 25 initial dose was 10 units twice daily, and glargine initial dose was 10 units. That was the study pattern over here. The primary objective was obviously to compare the duration of maintaining this A1C goal between the two groups, which one achieves better. Next one. Right, so this, if you see over here, the Humalog Mix 25 versus glargine, right? If you are seeing the gray one into the insulin glargine and the Lispro Mix 25 into the dark maroon, right? So this greater durability and percentage of patients are achieving A1C less than 7% for Humalog Mix 25 over glargine, that is basal. Yeah, next slide. And over here, we can see that the durable trial, right? So we have this safety profile as well, right? So with the safety profile, similar rates of hypoglycemia between Humalog Mix 25 and basal insulin. So you see that with Lispril 49.9 and 45.3 with Clargine. We mainly look after when in the studies about the hypoglycemia, mainly there are multiple other studies where we look after so many other adverse events and the serious adverse events or any kind of the endpoints or something like that in the phase 3 and 4 trials. But over here, when we look after all these studies, we mainly look for the hypoglycemia when we are comparing straight away the basal with the premix, right? So, but that safety profile is quite good enough over here with 49.9 to 45.3, and that doesn't raise any concerns across the Clargine and Humalog mix comparison. Next slide. So the insulin initiation options, the overview we have over here are the fasting reduction, postprandial reduction, HbA1c, durability of the glycemic control, hypoglycemia, initiation of this convenience, right? And all these things are there, whether it's suitable for the intensification, whether the robust clinical trials are there or not. So all these things, when you see, right, almost everything is being tick marked over here between these two. But if you see the better PPG reduction and better HbA1c reduction, as well as the durability of glycemic control, right? These three things are on a higher side with the Humalog Mix 25. And we have these things, if you see, regarding the intensification. So in the intensification, we have Humalog Mix 25 clear winner. Next slide. So this is the back to the case one, and this is what all we have discussed over here, right? And at the end of the 3 months, HbA1c was 7.5%. Interest of time, I will not go deep into this. Next slide. The case study 2, very quickly we will take this through. The tailoring insulin initiation with the high mix of, yeah. Next slide. So the case study 2, a very quick look at the background of the Mr. RTS, the 51 years old person, right? And he's having the weight of 77 kg, and he consumes high carb diet regularly, being treated for almost 10 years by now, BMI 28.1, and BP 128/90, heart rate 74, HbA1c 9%, fasting 165, postprandial 270, create 1.2, with that EGFR coming down to 69, and urine albumin creatine ratio is 72. So that is a little bit on the higher side than the normal value of 30. So that's in between 30 to 300. And these are the labs. Next slide. The reason for visit is obviously uncontrolled DM, and he has the family history of hypertension. To his father and mother is also having the type 2 DM, right? And the medication, he is on the sulfonylurea, DPP-4, and metformin with the atorvastatin 20 mg once daily. Right, in sulfonylurea, he's having glimepiride 2 mg and vildagliptin 50 mg BD going on, right? And he's having the high carb diet with the preference of processed food and the high calorie snacks. Next slide. Yeah, so the diary of the self-monitoring blood glucose, if you see his diary, the current A1C is 9%, and the highest, if you are seeing over here, has touched the 279 as well on one day, that is on the Saturday. If you see the before breakfast, after breakfast also, he is touching almost 273 after breakfast. Even before lunch, he's having 164, something like that, right? These are the peak limits that he's having. Even at the bedtime, he's having 276. So almost you see that the fasting being a 168 to postprandial up to 276 that he's having with this diary of his SMBG. Next slide. Yeah, this is what I have already discussed. Yeah, what is the highest values we got for the fasting and postprandial. Next slide. Right, so this is the basic problem in the India, as I say, that we are the carbohydrate capital by now, and the high glucose load in the Indian diet, greater postprandial exertion, and all these things are there, and the high lipemic peaks with the associated CVD, and ultimately, yeah, the increased glucosides and incretin activity in the gut, like that is causing you the higher lipemic peaks with the associated CVD. Next slide. What is the clinical evidence to initiate over here with the Lispromix 50? Next slide. Right, so over here we have these patients with the uncontrolled on multiple OADs, right? Phase 4 open label trial has been done, that is the randomized trial was there, and the East Asian subjects were included with the type 2 and inadequate glycemic control under OADs treatment. Both LM25, LM50 improved glycemic control over 26 weeks of the time, right? So almost the 6 months, you can say so, right? Over here you see that quite a good control, but with LM50 we have got a better control, right? So yeah, next slide please. And if you see over here in this population and all these things, so at week 26, we are having the LM50, Lispromix 50 group had significant more subjects achieving HbA1c targets less than 7% compared to LM25 group. And with that, we have the better post-meal glucose control after morning as well, and the evening meals as well, and the bedtime blood glucose levels as well compared to the LM25. Next slide. And the patient started Humalog mix 50, 12 units before breakfast. Dose was titrated 1 unit per day to achieve the SMBG targets. When we are coming back to this case with the evidence completed. So yeah, patient started on this with this, and the dose was, yeah, this was done. Can we go to the next slide? Right, so these are the first follow-up. You are seeing the target range was FPG of 80 to 130, and the PPG is almost less than 180, right? And his sugar levels after the fasting as highest is 149. Earlier it was 166, you see, and the after lunch also and the dinner time also it has reduced than the before, right? Almost 30 to 40 that we can see over here. Yeah, 231 and something like that he has achieved. Next slide, quickly. Right, so these are the targets at the first follow-up that we just discussed. The lowest that achieved was 149, and the peak has gone once to 273, but 236 also we have achieved, and before lunch also we have achieved 146, right? So these are the two things, that is the baseline and the first follow-up. So this is what baseline is there on the blue line that you see, 267, 273 that we discussed earlier, and with the follow-up we have reduced from 166 to 149, from 267 to 221, and 273 to 236, right? And yeah, next slide. So after 6 weeks, the pre-breakfast dose by the patient was 15 units, and second dose of Humalog mix 50 was introduced 10 units, right? Next slide, please. And the second follow-up visits after starting premix insulin and timely dose titration. Over here, we have achieved a good number of the levels, right? 134, right? And the postprandial also we have achieved somewhere around 170, right? From earlier it was baseline was 273, and HbA1c is also reduced to 7.3. That is the great control that this patient has showcased with this treatment of LM50. Next slide. Right, so this is what we just discussed. I have already discussed this with the baseline and the present follow-up with this first follow-up and second follow-up, as well as the baseline. You see 267, 221, 175, the drastic change that we can see, and then the 273, 236, and 176. So a couple of follow-ups, and patient is in line with the targeting range. Yeah. So 4 weeks later, he stabilized at 15 units before breakfast and 12 units before dinner. And at the 3-month mark, effective glycemic control was achieved, as evidenced by A1C level of 7.3. Next slide. I think we are done. Yeah. So this is the last slide. I will just take the 30 seconds to conclude my talk. Yeah, I think I have taken 2 or 3 minutes more of yours. I'm sorry for that. So the conclusion, when we see of this premix, over 80% of people with type 2 in India poorly control blood glucose levels, as we see, and with an HbA1c more than 7%, in spite of having 3 OADs, they are showing significant gap in managing the condition. So controlling fasting hyperglycemia is crucial for us, right? And with Lispromix 25, this shows greater durability compared to basal insulin, and that suggests that it may offer more sustained glycemic control over the time, right? And Lispromix 50 could be the safe and effective choice as a starter insulin in patients requiring this tighter PPG control, right? So yeah, with that, I would conclude my talk. Thank you so much for patient listening. Yeah, over to you, sir.
Thank you, Dr. Manthan, for this enlightening talk about the premix insulin, what is actually the theory and practical aspect where you have shown with your cases that how to implement this. I've got 1-2 questions for you. Actually, I got 4-5 of them, but I selected 1-2 for you. The first question is very pertinent, and this is why I want to ask it first, because there is a notion behind premix that it causes hypoglycemia. Now, it has been said multiple number of times that it increases the risk of hypoglycemia. So how do you deal with this hypoglycemia thing when you initiate a patient on premix insulin?
Okay, so see, first when we talk about this, we have the safety profile. That way, if we compare this with the basal, both are having almost the similar safety profile of the hypoglycemia incidence. So the management would be as similar as that. I usually, what I do in my practice is I make patients very much informed about what they are being initiated on that. My a particular file would be having those details, that if you feel any kind of the hypoglycemia, what could be the symptoms on that, right? But I have to be very honest, in my practice, I have hardly seen anyone facing the hypoglycemia episodes with this initiation of the premix. So what I do clinically is I start them with a very minimal dose, and based on that I ask them to do the SMBG at least every 2 or 3 days, and based on that I up titrate or down titrate that dose, and that would help us. So yeah.
Yeah, that is very true. Sandeep sir, what is your experience? I have not seen much of hypoglycemia with premix when
Absolutely.
we use it judicially.
Actually,
What do you say?
issue is that premix has got one problem, that it is a totally fixed. It's everything is fixed. Either it is 25/75 or 30/70. They are both are this mixed. So you cannot alter them. So you cannot juggle with R, or you cannot juggle with the Lispro, or the protaminated Lispro. So you cannot juggle with that. So it's absolutely fixed. So another thing that is important, if the patient misses the lunch and patient misses the evening snack, then there are more chances of developing hypoglycemia, because you are
Very
titrating the dose in the for the breakfast and for the dinner. Postprandial part will be taken care post breakfast and post dinner. And what about the lunch? And you are thinking that your as part this protaminated Lispro will take care of your lunch. But if patient misses lunch and evening snack, he is going to have some sort of hypoglycemic symptoms. So you have to tell patient that it has to be 3 meals definitely. He has to take something definitely. Or if he is missing lunch, he has to keep on checking blood sugar at the time of 2 p.m., at the time of 5 p.m., so that to avoid this type of problem.
Very true, Sandeep sir. And it is a very wonderful point which you highlighted. I call this a premix insulin as an insulin for retired person, because
Yeah.
they have usually their meals on time. So I keep this for the people who are taking meal on perfect time, because young executive, I really avoid premix because I don't know when they are going to eat. And that is what causes problem. You are very right in saying this, that the quantity of carbohydrate along with the timing of carbohydrate, it creates sometimes problem. Alok bhai, if you are around, can you come over, because I can see you are there.
I'm very
Because
much
Alok
there.
bhai, being an astute clinician, he would be sharing his own views from the city of Mumbai, how the patient behave with premix insulin in Mumbai. Let us see. Hi, Alok bhai.
Good evening and a warm welcome, and my respects to everybody here listening to Dr. Manthan. Fantastic talk on premix, one of the toughest insulins, cheapest insulins, but very difficult actually to master it in clinical practice. And irrespective of whatever anybody might say, with due respect, patients do land up in problems. It's a very skilled clinician who knows how to. It's like playing with a juggle ball. How you juggle around, it's very difficult to. And a very skilled clinician does that. We should take it to the AI level and discuss that. No, but what is important is what's important is, see, India is a premix country. It's the cheapest insulin, and whether you like it or not, most patients eventually land up with a premix, and they love premix because it is cheap. India mein paisa sab kuch hai, and patients don't want to spend on health and money. So a good titration, a good way to. But what the problem with premix, what I feel now, Bharat Bhai, is that you need a very good dietitian, or you need a very good diet control. It's a headache for a dietitian and the doctor, especially because you change the diet and premix cannot keep up with it. And if you don't change the diet, and that's not a practical solution, with the non-premix second generation insulins, diet changes do not alter the sugar levels much. And one aspect which I think it's beyond the scope of today's talk, but something which I thought is very important, is rather than measuring SMBG, which is not practical, and rather than depending on HbA1c and fasting TP, which is a very poor way to determine your glycemic control and variability, which is very common with premix. If you can do a CGM and look at the time in range, that makes a whole lot of difference. I do a CJ with my patients on premix, and then I can really adjust it in a much fine-tuned manner. Doing SMBG and doing HbA1c becomes very difficult to manage with the premix. But that's my thought. Maybe you will agree or not, but it's a costly way to do it. I mean, combining premix with a costly CGM is not a. I mean, marrying a celebrity film to a normal working banker is not a marriage option. So वैसा हो जाता है. But then believe me, it works very well when you do a CGM, or like what Bharat Bhai and me do. Take the SMEG report, put it in the artificial intelligence, and get a conversion to a CGM, and we do it that. Sorry for
Very,
that
very
answer,
true,
a
Alok
long
bhai,
answer,
very
but
true. And actually, although it's a long answer, but it is just of all the story around premix insulin. Dr. Manthan, what is your take on a single shot of a premix insulin? I have used it many times. What is your take on this?
I
Let's say
have
lunch,
not,
single shot 30-70. What is your take on this?
to be very honest, I use it very carefully. If I need to use it once in a day, I usually prefer in a twice a day. I am having hardly 10 or 20% patients whom I might have initiated with once a day for the premix. Yeah, 30-70 as
Sandeep sir, any experience?
Yes, yes. Actually, not with the 25-75, more with co-formulation.
Yes.
And
well. Yeah,
actually, co-formulation is made for this type of thing, that you pick up the largest meal, maybe
Yes.
at the time of dinner, and second day it may be at the time of lunch, or third day it may be your breakfast. You can alter that. So that is the
yeah.
beauty of co-formulation. There you can use it, but here, not much use. I have not much use for once a day, 25-75.
And Alok bhai, what you say about to those patients who are insulin phobic, initiating with a premix single shot a day, how it goes along in your part of country?
insulin phobic patients, believe me, it is insulin phobia even for a basal insulin.
Yes,
They don't
Yes.
like the needle.
yes.
And a lot of that junk knowledge comes from reading WhatsApp University and Google Baba and some other paramedicals. So once you remove that, getting premix is not difficult. But I've given once a day premix. I mean, to agree with what Sandeep sir said, Rhizotech, eventually we end up giving co-formulation twice a day also.
Yeah.
Because major meal generally doesn't remain major meal with our Indian
Yeah.
diet. So I've given once a day premix. I'll work, it works commercially. The sugars come down because the moment you give aspart or something, the sugars come down. Patient feels happy. He sees that happiness for 1 or 2 months. Very happily goes on a 2 dose of premix because what they see is the sugar report. They don't see cardiac benefit. They don't see renal benefit. They don't see retinal benefits. Now I'm talking from a very practical point of view. One shot of premix, I tell them, कुछ नहीं से इतना दो, एक तो चालू करो कम से कम, get
Yes.
comfortable. Then they go on proper dosages of premix. And Dr. Manthan, with due respect, I end up giving 3 shots of premix.
Yes.
And sometimes I end up giving 4 shots, one basal. And sometimes I've given 3 shots of premix to get real good control. I have a elderly patient with a creatinine of 2, and he's on 3 shots of premix and he's doing very well. And I tell him to go on basal and, go on a GLP with it. He's not willing for that. ऐसा खर्च नहीं करना है. That's the reason. But one shot of premix does work. And let's be practical. How we say we should not give steroids in asthma. It is not the right way to treat. But when nothing works, you have to give steroids. When patients don't listen, give one shot of premix, show results, and get them online. Being very practical here.
I agree with you, sir, that like even 3 times a day of the premix. But yeah, I more agree on the co-formulation. I also prefer, let's say, when we have touched the topic of the Rhizodec and the co-formulation, I also prefer once a day. But I just want to understand from all of you on that aspect also, that do you guys really prefer Rhizodec twice a day? Because I sometimes feel that it is kind of the waste of molecule, that is the long acting one over there, Dagludex. So I usually very cautiously prefer it in the twice a day. I usually keep Rhizodeg once a day only. But so I just want to learn from all of you the habits, because that how your experience
I
with
agree
them.
with you, but trust me, once a day doesn't work in the long run. It doesn't work.
Yes.
Patient का diet major meal कभी major meal रहता नहीं. It keeps shifting between lunch and dinner, especially with
Right.
executives who are flying. Like suppose you
Yeah.
are the patient, I'm the patient, Bharat Bhai is the patient. Lunch in London, dinner, and I mean I don't want to go into that. But lunch, I mean the meal doesn't remain one meal per day. Since I'm practicing in an area where Hiranandani is close by, people are working in the night, sleeping in the day. They're working for US and all. There are a lot of people. There are truck drivers whose meals cannot be quantified. I get truck drivers and food sellers. Lunches are different, dinners are different, diet advices are not followed. You give twice a day, it gets a better control. I mean, we don't talk about it, but it happens that way.
Yeah, absolutely agree.
But it is said like this, Alok bhai, that you cannot plan an insulin regime for a person who is eating whole day round. So for a person who is eating whole day round, I think the pumps are
Yes.
the key thing
Yes.
which we can plan about. But pumps are non-affordable mentally to Indians. It is actually not affordable, but it is non-affordable mentally to Indians. And moreover, there is a pump phobia also. So premix gives us a slight advantage in restricting or minimizing the number of pricks. Regarding co-formulations, you are very correct. giving it twice a day sometimes feels useless when we compare the meal logs. The meal logs becomes the key, as Alok Bhai is told. We should, before initiating any insulin, I would say, and the house will agree to it, we should do a recall of 7-day diet. A 7-day diet recall will land up us into a higher position, and it will save our patient from any hypoglycemia or any excursion. We will be better able to know, and like Alok Bhai and me do, we just put these values into AI, and then AI tells us that these are the points where we need to look, and these are the points where we need to skip the insulin. But all said and done, ultimately it comes to a counseling, a good level of counseling, a good level of dietary recall, and that is what is the take-home message for our audience from this talk. That premix is, although insulin which should be used with caution, but it is absolutely not a bad insulin. It is very good if you are using it cautiously in a very disciplined patient. A disciplined patient means who is having a set meal at set times in set manner. So for all those patients, you can go ahead with premix insulin. So thank you, Dr. Manthan, for this enlightening talk, and you have opened the innings so well that you have set up the agenda, and now Dr. Alok Modi will take over from here because he will be the person who will be giving us an overview about whole of the insulin therapy per se. So what is the role of insulin in diabetes management? He will be talking at a broader view about it. To introduce him, I think whole of his lecture timing will go away if I start introducing him with
Let's just
all
start.
his accolades. Alok Bhai is a very good friend of mine. He is a very good gentleman, astute clinician. He's co-founder of Kevalya Hospitals. He's co-founder of Doc Yantra and Dr. CI also. He's founder of a very beautiful group, Tech Doc by Dr. Alok Modi. I request all the audience to actually be interested in this group, because this group is actually having technology updates in and around healthcare. He's consultant physician at Jupiter Hospital. He's been awarded in the top 20 diabetologists of Mumbai. He's co-editor and published chapter in digital technology. He's a writer par excellence. He has published various papers. He was awarded top 10 reviewer award by RSSDI and Springer in October 2023. In 2024, he got a internist of the year award, which is a reflection of his clinical accolade. And again, he is board certified by American Board of Artificial Intelligence and by Massachusetts University in Artificial Intelligence. So a doctor who is talking to robots and making robots work the way he likes. Over to you, Alok Bhai.
Thank you, Bharat Bhai. At the outset, very dil se shukriya for such a warm introduction and giving me the opportunity to be here, to be pan-India and Indore, sitting in Mumbai. So it's very sweet of you. And whatever accolades Bharat Bhai has spoken about me, I mean, we don't need to talk about it. He's way ahead in AI technology and many things. Every time I talk to him, I learn so much from him. We have wonderful interactions, and we hope to see this world a better place few years from now, when technology and medicine will, marry hand in hand and take this patient care in a much better manner. Actually, I'll just say one line here. I always wanted to be an engineer and doctor. I think most of the intellectual people after 12 had this paradigm shift, whether we go for engineering and medicine. Today, we are fortunate that we can be excelling in both and fulfill our childhood dreams that we could be an engineer and a doctor at the same time. Believe me, that's something, a topic that we should discuss some other day. It's a wonderful talk and thought here. But what I will do today is I'm supposed to cover insulin. Covering the entire insulin in 15 minutes is very difficult. And after listening to Dr. Manthan, who has covered it so beautifully, I will try to cover a broad aspect of basal insulin and modern generation basal insulin, because that will throw a different take. So can I do my screen share, Bharat Bhai, and we can start?
Yes, please go ahead.
And thanks for the lovely introduction again. So I think it's my slide visible now.
Not yet, Alok Bhai. Yes,
Yes,
it
yes.
is. Thank you.
Okay, so I just move ahead here from here. So, okay, so basically, insulin is required not for type 1 and or type 2. It's required for practically any diabetic. And before I go ahead, and I guess there will be a lot of clinicians here listening to us, besides all this type 1, type 2 in classification, we need to understand one thing very clearly. Insulin does not give you cardiac benefit, it does not give you nephrology benefits. Then why do we give insulin? 2 to 3 things, very simple things, very basic fundamental things is a non-diabetic is treated by nature with insulin. The molecule which a non-diabetic is using to control his sugar is insulin. The molecule which a non-diabetic is using to keep his body healthy fat metabolism, lipid metabolism, kidney control, moving sugars in and out of various organs is all insulin, then why are we against insulin? Insulin is one of the most fundamental molecule which has revolutionized the approach and death rate of diabetes. If you go back in the history, you realize people used to die with diabetes. When they were given insulin extracts from animals, they started surviving. That is how Benton Benting became famous. And second thing, very important, is type 1, they don't have insulin because they're not producing. Type 2, there is more insulin. It's like Bombay city. We talk about type 2 as Mumbai city. There is a lot of water, but there is no water inside the city. We are also sitting with lack of water, but we are surrounded by gallons and gallons of water because that water is not reachable in your house. So there is a lot of insulin in the blood, but it is not working on the cells because insulin needs to tie up like a lock-in key on the cell. And then it opens up the gate by which glucose can go inside. So one basic fundamental thing, after you eat your food, that glucose has to be converted back to starch, back to glycogen, and to be stored in liver and muscle and kidney, primary organs, where that it is stored so that it can be broken down when you are not eating food, when you're fasting. So that pushing of glucose from the blood into the cells is done by insulin. So in type 2, what happens is insulin is there, it's working fine. The receptors are defective. The lock is defective, so the key doesn't work. In the bargain, the body tries to produce more and more insulin. The pancreas is overworking. A day comes when the pancreas burns out and a type 2 becomes like a type 1 and type 2. So to prevent that, if you can start insulin day one, instead of metformin as a monotherapy, when the sugars are borderline, when the HbA1c is just 6.7 or 6.8, you will give rest to the pancreas, and it is said that in the future, pancreas burnout will be much less. He will not develop type 1 at the end of 15 years of type 2. So that is one of the things we should remember, and we should start insulin as soon as possible in a patient whenever he's comfortable. Because, and there is another study which I'm not showing here, which has shown that a lot of inertia comes from the doctors, not from the patient, because we are scared of losing our patient. So we agree with our patient and tell them, ki, theek hai, aap insulin mat lo. Anyway, I'll come to that. So there are rapid acting, long acting, basal and all that. Today we have insulin pumps and we have insulin pens, which are much better than extracting insulin from a vial into a syringe over here, right? Another important thing which I'm not showing in the slide, which is important, is that the vial insulin comes as 40 IU per ml, whereas the pen insulin comes as 100 IU per ml, or the latest Toujeo, which is Glargine, which is 300 IU per ml. So there is a lot of difference in the concentration, and we have seen a lot of patients buying the vial and putting it in the pen and giving themselves, telling the doctor we are taking insulin pen. In the bargain, they're giving a wrong dose than what you're prescribing, and they're landing up in the ICU. So ask your patient who are prescribed on insulin pen, are they buying the pen cartridge or are they buying the vial? Because there's a big difference in both of them. That's another thing. And when you're putting somebody on insulin, you have to monitor blood glucose levels. I'm just covering the real basics here. I'm not going into too many details. Dr. Manthan has covered it very well. The complications with insulin are 2 and 3 things. Very important. One is hypoglycemia happens with insulin. You can have a hyperglycemic crisis with insulin. If, like Dr. Sandeep said, Sir said, that the lunches are skipped or the meals are not taken properly and patients start overeating later on. And what Dr. Bharat Bhai very rightly said, that you get a lot of hypoglycemia no matter how advanced type 2 or second generation basal insulins happen, because you need to adjust the dosages and the timings very carefully. Couple of other complications with insulin besides hypoglycemia is weight gain. Why do you get weight gain? Is because it's an anabolic hormone. Remember one fundamental thing, in a non-diabetic, insulin is released from the pancreas into the portal circulation, and the liver makes some changes to the insulin, and then it goes in the systemic circulation. And till today, we have no understanding what happens in the liver, that this insulin does not cause weight gain, does not cause steroid side effects, and does not cause complications of hypoglycemia from the body, no matter what happens, because it goes via the portal. Something happens in the liver that we have not understood. But when we give insulin, we are giving it in the systemic circulation, and we are giving a direct dose in the original form in which it has been designed, and that is why you get an anabolic effect, you get weight gain. Multiple injections on the same site called lipodystrophy, lipohypertrophy, and lipoatrophy, both of which are bad because you get around 10 to 20% reduction in the dose. So if you're giving 20 units, you end up, patient might get up 10 units or probably 12 units only, and that's very important. And we need to look for that small nodule and palpate it, which may not be visible. And we need to encourage our patients to rotate the sites of insulin, which again, a lot of insulin management is not just giving insulin, but insulin counseling, which either our diabetes educators should do or we do. When many general practitioners and physicians do not take pains to spend time with the patient on initiating and maintaining insulin, and they'll end up in complications. There could be allergic reactions, obviously, which is something which we all know. After all, it's an antigenic substance and it's a small molecule can cause. Now I'm coming to basal insulin. I will talk of basal insulin. Now, what is basal insulin by definition? Basal insulin is an insulin which is produced irrespective of blood sugar. So in a non-diabetic, the insulin which is produced 24/7 by the pancreas, even if you're fasting for 7 days, let us say you go on an unshan, you go on a strike, you're not going to eat for 7 days. In spite of that, your pancreas will give a small trickle of insulin 24/7, and that is called basal insulin. And I don't know how many of you know, but the dose at which it is produced by a normal person is 1 unit per hour. So you end up releasing around 24 units of basal insulin, and this is irrespective of the meal. And on top of that, when you have a meal, insulin dose is pushed to counteract the glycemic load. So a true basal insulin, as you can see on the left side of the graph, let me switch on my pointer here, is this basal insulin. It's a flat curve. But with a premix or with the first generation basal insulin, you never get a flat curve. You get a shoulder effect. You get a rise in the insulin when you give an injection, and then it goes down. So there is a shoulder effect when there are rebound hyperglycemia because of hypoglycemia, and there are problems. So an ideal basal insulin that you're synthesizing in the lab should be a flat insulin. So there should be minimum variability and it should work at least for 24 hours. That is the criteria of an ideal insulin. Just let's run through the history. You started insulin because of Benting and Best. You started giving pig insulins and bovine insulins. You started creating NPH insulin, which is a part of Premix, which Dr. Manthan covered very well. And since I'm here, I'll just show you one thing. Another important reason why Premix has caused problem is, if you see the insulin carefully, there is a small ball bearing inside, which is supposed to mix the premix, the basal insulin as well as the rapid acting insulin. Many of the patients do not take pains to rotate the vial in their hands. They don't mix it, they directly inject. They end up injecting most of the time the rapid acting insulin and not the basal, which is a protamine insulin and NPH. So what happens is they'll end up in hypoglycemia because of that, and they do not get the proper dose of insulin. It's important to tell your patient to mix the vial at least 3 to 4 times, because the PKPD, pharmacokinetics and pharmacodynamics, change in a premix without mixing and with mixing. That problem is not there with a recombinant insulin like Rhizodec, because here the PKPD doesn't change and you don't have to mix because it was like a simple solution. Then came the era of Detamir, which is a basal insulin, and Lantus Glargine U100, which we all use very heavily and very regularly, with the problems of basal insulin that I just spoke about. And Detamir and Glargine are known to be the first generation basal insulin. The half-life which was there earlier from 5 to 10 hours has extended to 12 to 19. And today is the era when we are using Digludec, which is a true second generation basal insulin, and the same Glargine in a concentration of U300, which is a true basal insulin, and their half-lives are running to 25 hours. So the profile is very flat and hypoglycemia comes down. So if you look at Degludec, you see the profile is literally very flat. The PKPD is very well balanced, and you're getting a true basal insulin over 24 hours. So the onset of action, I'll cover both the insulins one after the other. You see Glargine U100, the onset of action is 2 to 4 hours, whereas Degludec, the onset of action is 0.5 to 1.5 hours. Glargine generally does not last beyond 22 hours. And in reality, no matter how much we say it's a basal insulin, trust me, most clinicians end up giving 2 shots of Glargine in a day to compensate for the hyperglycemia that happens because of the shoulder effect when you put somebody on U100 Glargine, which is popularly known as Lantus, coming from the stable of Sanofi, and Idecludec coming from the stable of Novo Nordisk, runs beyond 24 hours. So that's important thing. And if you just look at this data here, 2 euglycemic clamp studies in type 1 diabetic patients comparing U100 Glargine to Degludec, you see that the variability is much less with Degludec compared to Glargine. So that's important to understand, because this is important in type 1 as well as in type 2. And if you look at the interday, this was intraday. And if you look at the interday variability over here, you look at this R2 glycemic camp study on a day-to-day basis, you find that the variability is much less with the second generation basal insulin compared to U100 Glargine. Couple of data here, the Switch Pro RCT randomized control trial of the Switch Pro, where people were put on one insulin and then they were shifted back to the other insulin. So they started with Degludec and they shifted to Glargine. showed the superiority of degludec over glargine. And as you can see, the mean time in range, which was 72.1 in degludec, was around 70.68 for glargine. So what's important is it is better in glycemic control, not phenomenally better, but marginally better. Now, if you look at the other basal insulin, which is U300 or Toujeo, which is popularly known, the fluctuations on a daily basis is very less. Hypoglycemia in both type 1 and type 2 is very less. And what's important is nocturnal hypoglycemia. If you see any hypoglycemia study, you will realize that around 60% to 70% hypos occur in the night, and they're asymptomatic hypos. And most of our elderly people who die at the nocturnal time, and we attribute it commonly to saying that so and so person had a heart attack in the night, has actually died because of a asymptomatic hypoglycemia occurring in the night. And that is very bad, because if you're losing a patient of loose motions because he's gone into kidney shutdown and you have not been able to replace the fluids, and if you're losing a patient and dying because of hypoglycemia, these are not good things, because these are totally preventable deaths. So that is one of the disadvantage of going on first generation insulin and premixes, that your person can die with a nocturnal hypoglycemia, which is a asymptomatic hypoglycemia, because as time goes by, after 10 years to 7 years, you develop autonomic neuropathy, and the patient is not able to build up a defense mechanism, get the sympathetic system into action because of hypo, and they don't retaliate back to build up the blood sugars in the body because of hypo. Another point to be noted and kept in mind is, with something which I'm talking out of my experience, a lot of these people are on metoprolol for hypertension, and I desist that, because metoprolol prevents somebody from coming out of hypo. If you have to give a beta blocker because of cardiac failure or hypertension, I generally recommend or put a person on a beta 1 selective cardioselective beta blocker, because then the hypoglycemic management becomes better for the body. But a metoprolol or tenolol used as a antihypertensive in such patient is playing with fire, unless you're giving metoprolol for reduction of the cardiac size post MI. That's a different story. So I've just covered one or two important poles in clinical medicine. Very important that if your persons are on tenolol or atenolol or metoprolol, many general practitioners are giving it left, right, and center for management of hypertension. They're excellent drugs for hypertension, but this is a problem. Most of the diabetics have got hypothyroidism, and they are prone to getting hypoglycemia, especially when your diabetics are developing renal failure and they're developing senility or elderly age. These are the people one should be very careful with non-selective beta blockers. Another important point to be carried in mind when somebody is on insulin is, when the creatinine rises or the renal clearance decreases, EGFR decreases, insulin stays longer in the blood and can cause more hypos than before. So the classic story is, when you monitor your patient over a period of time, you realize the patient sugars have started coming down and the insulin requirement has started coming down. And patient is happy, doctor is happy, we both are doing well. It is nothing to feel happy about. The patient is developing renal failure and is going into hypos because of renal failure. And hence you are reducing the dose. It is nothing to feel good about. So you check for the kidney function. The creatinine could be normal. Serum creatinine is in no way a parameter of diagnosing renal failure. Many general practitioners look at the creatinine 1 and they're happy. And many labs give a normal creatinine as 1.5, which is erroneous. Any creatinine above 1 is always and always abnormal. A creatinine 1.1 is very bad. It is not good. So what you need to look at is EGFR. And another clinical pearl is, don't spend patients' money of some 450 rupees to do EGFR. You can calculate it on your own calculator. There are a lot of formulas and a lot of apps available by which you can calculate. So if EGFR is coming down from 120 or 110 to 60 and 70, get careful with your insulin dosages, even if the creatinine is showing as 1.0. So you need to give precision medicine. You need to individualize a person on insulin who's on multiple oral drugs, who's an elderly people. A senile or an elderly person 70 plus will have creatinine clearance low because of age, irrespective of serum creatinine and kidney status. A person of CKD, a person on co-formulation, and a person on multiple oral drugs. So let's jump through some case studies very quickly so that I don't take much of your time. Multiple drugs person, landmark study, very classic study. More than 3 drugs of oral, adding a 4th drug is useless because the glycemic control is not much. The HbA1c control does not come down below 0.1 or 0.4 or 0.3. So adding a 4th drug does not give any benefit to the patient unless you're adding a drug like GLP agonists, which our very esteemed clinician and good friend Dr. Shambo is going to talk about after this, or you're adding a drug like SGLT2 inhibitor, where the benefits are more cardiac and nephral rather than glycemic control. So 52-year-old man, BMI 32, 6 years diabetes, businessman, EGFR 90, uncontrolled sugars 9.2, HbA1c, on metformin, SGLT2, sulfonylurea, and DPP4. What more can you give? You can't give. You've practically given everything here, right? You can add a voglibose probably. You can probably add a pioglitazone, but we don't know his cardiac status. He started on GLP agonists, but because of cost reasons and GI side effects, he could not go. Very reluctant to go on insulin because of inconvenience, because of his lifestyle, not because he's scared of insulin. And he started sulfonylurea in a high dose, got hypoglycemia, family history of CVD. Father died with type 2 diabetes and myocardial infarction. So he's scared of getting weight gain. So directly we started U300 glargine, which is Toujeo. Multiple trials, take control study, addition 3 study, bright study. All these trials have shown that the HbA1c could reduce by 1.4 and 1.6. Now there is a caveat here. Whenever you increase the insulin with a standard first generation or a premix insulin, at the cost of controlling glycemia, you end up giving weight gain to the patient and you end up getting hypos. So that is not something that we desire. Here, these studies have shown clearly that the HbA1c could reduce by 1.4 and 1.6, but the hypos were not increased. So that's important. Look at the CGM profile of these persons. When you compare U300 versus U100, the glycemia is better controlled. Hypoglycemia is much better. That's a more flatter curve, and a duration of action is much more. And another point to be kept in mind when you're giving a second generation, like Sandeep sir said very clearly, you need to be very punctual with your timing with a premix and a normal insulin. But with a second generation, with a Toujeo, you can safely give it a 6 hours window. So if your patient is a truck driver, if he's a fruit seller, if he's a doctor, if he's a lawyer, or if he's a person working in a corporate sector where he may not get time to eat his lunch or dinner on time, because today your prescription has to be tailored to the patient's lifestyle. Gone are the days when the patient would tailor his lifestyle to your prescription. So it doesn't work that way. You can tell your patient that if you have decided to take Toujeo at 6 p.m., you can take it safely at 12 o'clock in the midnight also. So I don't encourage my patient to be so lenient, but you can give them a 6-hour window that within 6 hours you take it anytime. It doesn't matter. So look at the addition trial and the bright study. Anytime 24 hours hypoglycemia reduced by 23% and 43% to the tune of, when you're looking at a value of less than 54 milligrams, which is very important. And if you look at CGM data, you'll realize that this is very relevant and the p-values are significant in a confidence interval of 95%. And that's very important, and that benefit you get when you're using a second generation. Nocturnal in both the data, 42% decrement and 35% decrement. Look at the second person we are looking here, which has got chronic kidney disease, CKD. 30 to 40% of your diabetics within 7 to 8 years start developing CKD. We need to check the EGFR. If you follow up your EGFR, if you recall your patient's EGFR 6 years back and now, you'll realize that the EGFR has started coming down from 110 to 190, probably hanging around 90, and most of my patients are hanging around 90, 95, which is not normal, which is CKD. And these 30 to 40% of your patients have normal creatinine and have diabetes. And these are the people who start developing hypoglycemia slowly, and you attribute it mostly to a very rigid diet. It's not because of that. So 68-year-old person, 30 BMI, 20 years of diabetic, EGFR of just 40, but an HbA1c of 8.8 on metformin, SGLT2, DPP4, ARB, Etorova, and calcium channel blocker for hypertension. Grade 3A CKD she has got two verticals here giving her kidney damage. One is hypertension and one is her diabetes. And she wants to be on target because she's worried about a glycemic control. And she knows that CKD can cause problems in the worsening of her life as well as retinal damage. So what drug will you choose in such a scenario? Very difficult to go on a premix, very difficult to intensify with a basal bolus regimen. There is no point adding a pio here or any other oral here. You start this person on a second generation basal insulin, you get a very good control, a decrement by 0.7 grams straight away. And again, the same thing, no weight gain, no hypoglycemia. So addition 3 trials, 1 to 3, all 3 RCTs, the deliver high risk trial, which was done in moderate renal impairment patients. as well as the post-hoc analysis of the BRIGHT RCT, which was used after the RCT was taken care of, was compared with the second generation idegludec. And all three trials data have very clearly shown that the renal failure problem was taken care of very beautifully. Third patient profile, I've got 2 or 3 more patients, which I won't be showing today because of time reasons here, but we are just looking at the elderly people here who have got diabetes and they are massively increasing in their diabetics. But what are the problems here? Frailty, cognitive impairment, dementia, urinary incontinence, fractures and falls. And I get a lot of these patients whose children are staying in the US here, they're staying alone. So for me, the problem here is Alzheimer's, cognitive problems, and urinary incontinence. And I have to tailor my therapy according to that, not just blood sugars. So patient C, 80 years old person, okay, BMI 27, 16 years diabetic, EGFR 64, HbA1c 9.9, on metformin, DPP4 and SGLT2, not on an SU because of his age, but I do give 0.5 and 1 milligram SUs in some people with some concern, and they do well. But here the problem is there is dementia, there is hypertension, there is neuropathy, there is proliferative retinopathy, though the hypertension is well managed, but the family members are concerned about hypo sitting in US, and you want to give a therapy which will not cause hypo because he's not getting monitored. So SUs are out, metformin high dosages are out. SGLT2 is something you can give. If I won't go into that, but the cutoff here is 64, the current cutoff is 40. So you can easily give SGLT2, but then he started on the second generation. So senior RCT study edition 1 and 3 RCTs, the BRIGHT RCTs, all 3 studies have shown very clearly the focus here is not on anything else but hypo. And we know that in 70 years of age, we are not very concerned with tight glycemic control, but we do not want hypo. So here, algorithm which could add a basal insulin like a second generation insulin here, basal insulin here, which is recommended by the current guidelines, the latest guidelines of ADA, would give him no weight gain, no hypo, but a very good control, and the caretakers can sit very comfortably sitting at a distance. So look at another insulin, which is idegludec. So now I'm coming to how do you start. The recommendations with idegludec is you can directly start with 10 units and then you start multiplying. And remember, it takes 5 days for the drugs to stabilize, for the insulin to stabilize. How does it happen? Because the half-life is 24 hours. So what happens is, if you're giving 10 units, next in the blood you will have, after you give another shot, you'll have 15 units. So third day you will have 7.5 plus 10, right? So that's 17.5. Fourth day you will achieve somewhere around 80. Fifth day you'll get, straight away you'll get 20. So you've started with 10, you want to reach a steady state level. After 5 days, your steady state levels are achieved very smoothly. And the recommendations is not milligram or HbA1c wise, it is straight away 10, and you can bump up by 2 or decrement by 2 depending on the blood sugar. And you can, if you're somebody is already on probably 2GO or a premix or some other basal insulin like a standard NPH insulin, you can directly shift 1-to-1. You don't have to adjust the dose. So the algorithm here is very clear. You can directly shift as soon as you want. But if somebody is on twice a day or thrice a day dose, then the recommendations are probably cut down by 20%. So instead of 10 units, probably you can go by 6 or 8 units. Now, the moment he's at target, maintain the dose. If he's not on target, there's hyper increase by 2 every third or fourth day. And if he's below target, come by 2. Now, I generally do not follow fasting because post-lunch goes out of the bounds. Though ADA recommends fasting, I generally follow TIR, and I can calculate TIR through AI through SMBGs, and I get a much better idea to control. But yes, with basal insulin, what affects is a fasting. Your postprandials are never affected. Now, when can I give this insulin? I can give it in pediatrics above 1 year. I can give it in adults. I can give it in pregnant women. The latest guidelines are very clear and accepted idegludec in a pregnant gestational diabetes. I can give it with any level of renal and hepatic impairment. I can directly start it in the ICU in a hospitalized patient rather than basal bolus, and that gives me a lot of leeway. So I've just tried to cover both the basal insulins in a quick manner. It's a huge topic, difficult to cover, but I just tried to cover. What I just want to show you here, it's important, is spend a little more time counseling your patients, like Bharat Bhai very rightly said. And these are some of the standard questions you get from your patient. Why can't I take tablets? When I can control sugar, why should I go on insulin? And that is the truth. Patients are willing to take 4 milligrams of glimepiride. Patients are willing to take 8 milligrams of glimepiride. And believe me, sugars are under control. Then why should I give insulin? A very practical question. And if you don't satisfy the patient, what happens? He's going to your neighboring the neighboring Spider-Man or the neighboring doctor. He'll be very happy to shift his doctor from you to him. I don't think I need insulin. Most of the patients feel insulin is a last ditch response. They feel insulin should be given only when everything is out, you're about to die, and your diabetes is out of control. Then the third thing is people start developing complications of diabetes like cardiac and nephral, and they blame it to your insulin. So you need to tell them that that is a problem. Hypos occur, weight gain occurs. You need to convince them that that is not because of insulin and you can take care of it. And somehow, I don't know why, some patients feel that insulin will damage my liver and pancreas. I don't know where they read that and come, but they do that. Another question that people have is, why should I adjust the dose of insulin when I'm paying you? You should adjust it, which is impossible. And here I would like to highlight you a beautiful app called Mitra, which Bharat Bhai has developed. It's a doctor in the pocket. Is Dr. Bharat Sabu in your pocket? Ask Mitra all these questions. Like a friend, it will tell you, cut down your insulin by 2, increase your insulin by 2, gives you very good results. You know, Sanofi had come out with this app called Make My Dose Insulin. There was this wonderful app which I used to use. I've forgotten the name. They've discontinued it. I would adjust the dose through that app very nicely. But if you use Mitra, this AI tool which is there on your pocket through WhatsApp API, it gives you beautiful guidances. Patient doesn't have to think the dose. Patient doesn't have to go into complicated algorithms, and it gets very well. Does insulin cause low blood glucose? Yes. Depends on what insulin you have. But with modern insulin, that's very much less of a problem. Does it interfere with your daily life? No, absolutely not. If you're using a pen, if you've got so much of leeway with iDeclutech, you can even skip a dose. So suppose you have given it today on Wednesday, you forgot to give yourself on Thursday, and you give it on Friday. Trust me, nothing goes wrong. With Tujio, you can skip for 6 hours also. Nothing goes wrong. And is it painful? I give them, what I do is, I give the first shot in front of me in the clinic. I give the puncture and I show them it doesn't pain. There's a silicone coating on the needle. It's a very fine needle. The problem is when you give spirit and you apply, you have to tell your patients, they feel more comfortable going to the neighboring nurse or some ayabai who's staying next to them. And they, especially the elderly people, they ask that relative to give. And what they do is they rub that area with spirit very nicely. They're trying to sterilize the needle. That silicone coating goes out, and then the needle becomes painful. Another important point over here to be told to the patient is, after every shot, ideally you should change the insulin needle, because the needle gets microfractures. It is not a financially viable option, but I tell my patients, please change the needle at least after 4 shots. Ideally, it is after every shot, because then trust me, your patients keep using the needle for 5 and 6 pence, and then the dose goes totally for a haywire. And a very practical way to check it, if you take the cotton and just rub it on the needle, if threads of cotton are caught on the needle, that means the needle has got microfracture. Do not use that needle. And I have done this. It saves a lot of my time. I'll just show you this. I hope you don't mind this. 1 second. Let me just remove the pointer options here. I've created this WordPress document here. If we are online, if I can go, okay. So I just give them a link to this and I show them. This is the WordPress. I it's okay. This is the, I hope you can see this. I've given a lot of photos here and I put up the entire data. I just asked them to go through this. I sent the link on their WhatsApp, they read it and they understand insulin saves a lot of my time. And it gives me a lot of people who are very comfortable with the insulin. And I get my patients on insulin and they stay on insulin. That is what I want. And they do very well. So to conclude my talk here, insulin is very much a part of life. Why should it be given? Why not? My question is, why not? If nature has made this molecule, then who are we to say that it should not be given? Second thing is, we need to spend time with the patient. Third is, don't force your patient. Even if he needs insulin, even if if his body is requiring insulin and nothing else will work, I don't force my patient, because he's the master of his life and we are ethically not bound to force our treatment on him. We'll let him get comfortable. A day comes when he willingly takes insulin from you. And I've seen those patients of mine who willingly are taking it even after 20 years. But those where I push them on insulin, they change their doctor and they stop taking insulin. So integrating insulin therapy in comprehensive diabetes management is huge. It's a big responsibility. What is not important is what insulin you give, according to me. What is more important is how much time you spend counseling the patient on insulin, pre-insulin, during insulin, and post-insulin. That I think is very important. And with that, I'll stop. And I will like to thank Bharat Bhai and everybody for giving me this opportunity. And
thank you, Alok Bhai, for this enlightening talk. And we like to welcome Dr. Shambo here, who has joined us. Now,
Thank you,
this was really an exhaustive and elaborate talk about the comprehensive role of insulin in comprehensive diabetes care. And I have 4 or 5 questions with me but I will take only two because Alok Bhai has eaten up most of the time of questions. I will be very fair in saying this.
You
But
gave me a
our
big
fault
topic.
is there.
Sorry,
Our
I'm
fault is
sorry
there.
about
We
it.
have given him an exhaustive topic. He could have
I'm
talked on
sorry.
and
I
on and on.
apologize.
So the first question which I have got is from Dr. Nagesh, and he's asking me. I ask patient to go on insulin, and this is a very common problem. I think I ask patient to go on insulin, but they refuse and they seek another doctor. How to handle this?
I'll answer it like this. You can't force anything on anybody. If I ask, I don't know if it's right. When I wanted to marry my wife, she said no. My friend told me one thing very clearly: don't go behind her, you will never get to marry her. Leave her alone. And she only approached me, fine, I'm ready. So I've seen that in my practice. Don't force your patients. Like I said, even if they want insulin, and even if medically you feel he should be on insulin. So you have a patient whose creatinine is 2.5, he's getting multiple hypos. You know, insulin is the right drug. He doesn't want it, you can force him. He's going to change the doctor. So I encourage my patients to I talk about insulin. I say, just listen to me. Let's just discuss insulin, but I won't write it. Do it peacefully, comfortably. Sometimes take 6 months, but once they start, they are perpetually on insulin. So the only solution I have is counsel your patients, remove their fears, let them get comfortable. जब तक वो comfortable नहीं होंगे, forcing it doesn't work. No matter with what drug, why only insulin? Even with GLP injectables. So the moment they are comfortable, they start. And I've seen one thing: when they get multiple hypos and they see the sugars going up and down, that's the advantage by using AI and CGM. They see those reports with their own eyes. They come back on their own. They say, yes, doctor, I feel you were right. I was wrong. Let's start insulin. And believe me, when they say that, they go on insulin. Never force them. The moment you force them, pressurize them, they're going to change the doctor.
Dr. Shambo, what's your take on this?
Absolutely. I think Dr. Modi has rightly mentioned the time is most important. We have to value our time and patient time also. And at the same time, we need to give more time to convince them. If they are not at all convinced, okay, we may write, for an example, if patient HB1C is 9.8, 3 or 4 drugs already on, but patient is refusing. We need to, at least we need to give 15 or 20 minutes time to explain everything. But after that, if he or she is not convinced, we need to give again another sulfonylurea, which is not actually a rational one, but at least we need to tell, please come after 1 month, do all these tests, and ultimately they become convinced. Maybe next month they will not come with with those report. After 2 or 3 months, definitely they will come back to you, and at least they will start insulin. And very important approach is, as Dr. Modi had mentioned, we need to start insulin at our clinic. Maybe it will be a dummy injection, but if we start like that, sometimes we need to take the need insulin in our own tummy. So that is also very much that convincing for our patient. So if we start that from our own clinic, so nothing like that. And one thing for sure, if I have some talk like this, that now we all are busy in webinars also, we need to exclude those patients who are ideal candidate to start insulin, because you know that this type of webinar, just for an example, last 10 or 12 patient I had seen in a very hurried manner. That's actually the story for all of us. So again, bottom line is time is very important. And I also ensured one paper we had recently published in IJDDC, why empathy is important regarding the counseling. So this, I think we are really fortunate. We Indian are really fortunate that we have a that great history of that counseling. May it be spiritual or may it be like that, but that counseling actually comes in our genes. So we are really, that in a higher position. We need to use our inheritance. I think that is my point.
Dr. Manthan, you must be seeing many patients like that in Surat. How you deal with them?
Yeah, absolutely. We do see that. To be very honest, I am having a one sort of a different approach with this. I'm a columnist in this leading Gujarati newspaper since 4.5 years. So I usually write column on every Wednesday. So I have almost covered, you can say, somewhere around 30 to 35 topics on diabetes, including the myths on insulin and all these things. So many of the times I counsel them in depth. I provide the time from my end. I demonstrate them with the insulin pen that how it should be like that. And above that, I make them more educated on this aspect that this kind of the in a layman language, sometimes you have to make them understand that what is the insulin and what is basically its mechanism of action in your body, that you don't need to worry about anything else on that. So that is the one thing. Apart from that, I keep some of my articles in the file in the local language as well as the patient's understandable language. So that might help them some sort of this literature, and that will encourage them to initiate with the insulin. Yeah.
Sandeep sir?
Yes, actually, everyone is saying same thing. Issue is that there can be 3 or 4 type of scenario. To put patient on insulin, you have to look at a fulcrum. On one axis, you have got insulin distress. On another axis, you have got insulin need.
Yes.
So I give you 3 situations. One situation is patient is failing on OADs, having hyperglycemia 9.5 and just asymptomatic. So here you know that addition of another drug will not lead to any benefit. But patient wants he should be on insulin, or patient wants he should continue oral antidiabetic drugs. But counseling is extremely important. We have to spend time with the patient to tell about the insulin that, look, your drugs are not working here. You will be having more high blood sugars, high AIE, and you will have many complications. So here you prescribe insulin, ask a patient to take insulin, but patient doesn't want. So there can be, you can give it time. Just as Dr. Alok was saying, that we should give it time. Patient may go away from you, may go to another physician, but he will definitely come back. You know it scientifically, nothing will work until unless you find some reversible factor, like patient is on steroids, or patient has got some really, patient is not compliant with the medication, not compliant with the dietary therapy, not compliant with the exercise, tries to do something. So that type of vocal insulin may work here. So that is one scenario. Another scenario, patient is getting into catabolic symptoms. Patient is developing complication, maybe diabetic foot is there, you find there is an ulcer development, or there is complications are coming up. So here you have to be more emphatic and telling them that we cannot give you more time. Whatever you are going to decide, it will be within 15 days. I'm going to put you on AGP. I'm going to put you on Freestyle Libre, and let's see the report. If you are able to do it, okay. But you know that after 14 days, what you are going to get, hyperglycemia everywhere. It will be beyond 200. So the patient will be agreeing after 14 days. But third scenario, patient is developing lot of catabolic symptom, developing DK, having GDM, or unknown or undecided pregnancy, that most of the time that happens. There you have to be very emphatic. You have to be very emphatic. You cannot give just with, say, 1 day or some hours, because here the time matters. So whatever may be the distress, you have to counsel, you have to talk with the attendants that this patient requires, this patient requires definitely on insulin immediately. So it all depends upon clinical scenario. But don't worry, if patient goes from you, he will definitely come back. We have seen in our own experience, nothing goes back. The patient will definitely come back. Science is always going to prevail. And even a rickshaw puller knows about the science. So be always scientific. Tell patient in a scientific way. So if you are going to give the answers to the patient in a scientific way, he is going to learn, he's going to understand everything. So it's a basic art, and that makes a difference between a physician and a diabetologist. So it's art and science blending together. And that's how we are having lesser number of hairs and graying of hairs. Yeah.
Very, very true, sir. Very true. And you have beautifully picturized it. And actually, we did a survey for RSSDI MMS Ahuja Symposium in 2021. Insulin initiation survey. And the starting point which we got was primary care physicians 80% of them were wary of writing insulin. And the reason they gave was, my patient will run away. So this is actually a fear in minds of doctors more than patients. And you are very right, and everyone is very right, that we should give more time to our patients, because we are not just mere physicians. We are treating their diabetes, and he comes to us with a huge hope. And secondly, guidelines are the key, because no one is going to save you in the court of law but guidelines. You can be a hero for few, but once a learned son or daughter from a engineering college of a rickshaw puller will come up and say that, why doctor, you have not prescribed insulin to my father? He is not illiterate, you are literate, and you have committed a crime. So whenever it is required, we should not feel shy of writing insulin. If the patient runs away, he is destined to run away. Let him run away from you. Alok bhai, just a quick closing note before we move out to the next.
Just one thing I do a little smart thing which I wanted to share. The patient feels reluctant, and I feel if I push, he'll go to another doctor. I say, so and so is a big name, let's arrange a second opinion for you. So I myself arrange a second opinion, talk to my colleague, send the patient to him. He goes very happily for a second opinion. I even send him for a third opinion.
Yes,
When I do that, I don't lose the patient.
yes.
Patient comes back say, अरे तीनों डॉक्टर ने बोला चालू करना चाहिए, डॉक्टर साहब आप सही बोल रहे हैं, चालू करो. That is another thing. I
Very good,
improve
very
my
good.
relations with my colleagues. My patient is happy. I definitely don't lose the patient. And I only say कि आप जाओ, and ऐसे आप मुझे 3 नाम बताओ जिनके पास आप जाना चाहते हो. I will talk to them. लेकिन आप उनको दिखा के और फिर उन्होंने बोला नहीं चालू करना है, मत करो. 200% patient goes on insulin. He starts. He's happy. See, his ego is taken care of. His fears are taken care of. And my colleagues are also happy. You took our second opinion. One thing which I've learned after some struggle in my practice.
Here. You are doing a very diplomatic thing.
It works very well, Bharat bhai. It works very well.
Yes, yes, definitely.
Patient feels very comfortable. किसी 3 doctors ने बोला,
So we now take on Dr. Shambo with us. Dr. Shambo is a very close friend of mine. He is a clinician and writer par excellence. I am fortunate to be with him in a few of the work we have done together. The most recent being the book on artificial intelligence for physicians, in which Dr. Shambo is a co-author, along with our dear friend Dr. Amit Kumar De and me. And also Alok bhai is contributing with us too much to AI. So a brief introduction of Dr. Shambo, because he is actually a DM in clinical pharmacology, most suitable for the person on this topic, which he is going to take today. He has published more than 122 articles. He is the author of Competency-Based Practical Pharmacology, Diabetes Monograph, Artificial Intelligence for Physicians, which I talked about. You should secure your copy with JP, although it is right now out of stock. He is a recipient of the Dr. J.C. Patel and B.C. Mehta Best Paper Award. He is recipient of Indian Academy of Diabetes Award for Innovation 2022. He is recipient of WIDF Innovator Award. A lot many awards are waiting for him right now to be given to him, because he is such an astute clinician and a wonderful writer. So he will be talking to us about what is the synergy between GLP-1 analogs, which are the new kid in the block, and insulin. Over to you, Dr. Shambo.
Thank you very much, Dr. Bharat Shabu. I'm really privileged to share this dais with my esteemed colleagues, and it is always great to share even his dais with you. So let's start today's discussion on insulin and GLP-1. If we can combine, what are the synergistic benefits? So hope my slides are visible.
Yes, Dr. Shambo, they are very well visible.
Yep. So one thing I want to clarify here, first of all, because many times we use synergism in a loose way, but need to acknowledge synergistic combination is something that a regulatory terminology, more specifically US FDA given a clear-cut guideline to say which combinations can be called as synergistic. And by definition, we know that if 1 + 1 is greater than 2, then we can call it as synergistic. If it is 1 + 1 equal to 2, following the mathematic formula, then it is additive. And if 1 plus 1 become less than 2, then that is something called as antagonistic combination. But in true sense, the synergistic combination, if we want to say, that should be understood by the magnifying glass of isobol analysis. And for this perspective, insulin and GLP-1 combination, whatever we have, they are not truly synergistic by regulatory definition. But of course, their action, their complementary action, they have some synergistic benefit. So on that background, let's start today's discussion with this famous cartoon show. And I think most of us will agree that our teachers always taught that we need to bring the insulin cat so that the metabolic mice could be controlled or could be run away, and our patient will have a very good glycemic control. But that time, I think we not given emphasis on this spike dog. So there is an important role of another hormone apart from insulin, and that is glucagon. So if there is glucagon increase inside us, that will cover up those metabolic mice, and we need to control that glucagon dog so that our insulin cat can play its role. And on that perspective, I think we need to give importance on different incretin mimetics. This was one of our review article where we want to emphasize on glucagonocentric approach to diabetes. And for that, we had gone through some great articles written by Professor Robert Unger, who had re-emphasized the importance of glucagon as the central pathogenic hormone in diabetes. We want to again re-emphasize on these numbers, that is the physiological levels of insulin in pancreatic islet cell, liver, and peripheral tissues are around 2000, 60, and 20 micro-IU per ml respectively. So what happens if the intra-islet insulin level decreases? The alpha cells in the pancreatic islets will be stimulated to secrete glucagon, leading to hyperglucagonemia. So if we understand the normal relationship of insulin concentration between pancreatic cells is to liver is to peripheral tissue, that is 100:2:1. But if I am giving only exogenous insulin, this ratio of 100:2:1 will become 1:1:1. So what happened? We are attempting to achieving intra-islet insulin concentration similar to the normal non-diabetic physiological levels. Then there will be we will land up to severe hypoglycemia. So there are some disturbance in this ratio, and for that, in type 2 diabetes, hyperglucagonemia need to be tamed well. So we should have initiated incretin mimetics, GLP-1 RAs at right time as a glucagon dog catchers, so that our insulin cat can control the metabolic mice well. And when we talk about dogma displacement inertia, we all know that our Western world thought about geocentrism. And it took almost 450 years after being disproven. They're still thinking about this geocentrism. So there is always a dogma displacement inertia, though that is not common in India. We have a long history of Barahomihir, who was not believing at all and had proved that geocentrism is a bogus idea. So we need to think about this whole concept of diabetes, which was only insulin centric. We need to consider it to glucagon centric. And I think this is a very important and interesting paper published by Robert H. Unger, who had mentioned the glucagon as an important factor which we need to consider while using any therapeutic measure. It increases hepatic glucose and ketone production, catabolic features present in insulin deficiency due to this glucagonemia. So if we made one mice, and actually that is one very important experiment conducted by Robert Unger. In that particular mice, when he had knock out those glucagon genes, there was insulin deficiency, but the catabolic features was not there. But where the knockout gene, glucagon knockout gene was not there in a mice and insulin deficiency was there. So there were catabolic features. So hyperglucagonemia is present in every form of poorly controlled diabetes. Glucagon suppressors, leptin and somatostatin, suppress all catabolic manifestations of diabetes during even total insulin deficiency. So glucagon suppression or inactivation, it has some therapeutic advantages over insulin monotherapy. Total beta cell destruction in glucagon receptor null mice does not cause catabolic manifestation of diabetes, and perfusion of normal pancreas with anti-insulin serum causes marked hyperglucagonemia. Glucose responsive beta cells normally regulate juxtaposed alpha cells. Without intra-islet insulin, unregulated alpha cells hypersecrete glucagon, which directly causes the symptoms of diabetes. And that is why I think we all know our nearest place, that is where we have two double star planet system. In our solar system, we have only sun. But here we have Kepler 34 and Kepler 35. So just like that, we need to give emphasis on two of our suns. One could be insulin, one could be glucagon. And even this pathophysiology, the natural history of type 2 diabetes, we can see here, I think my cursor is visible, and if we go by here, the incretin defect, that also starts very early with the onset of diabetes, just like the beta cell failure. You can see this is the incretin effect, which is going to decline. Similarly, the beta cell failure. And the incretin defect, that starts much earlier also, when even the diabetes onset not happened. So when we talk about core defects in type 2 diabetes, it was taught that hyperglycemia is the result of insulin resistance and insulin deficiency. But we need to also understand the diminished beta cell response, how the disbalance between increased beta cell load and decreased beta cell response ultimately lead to pathogenesis of type 2 diabetes, which may be accompanied by increased insulin resistance, increased food intake, gastric emptying, increased rate of nutrient absorption, along with increased glucagon secretion and hepatic glucose output increment. But at the same time, the insulin secretion and fast phase insulin response that will be blunted will result in hyperglycemia. But we talked about insulin resistance and insulin deficiency, but not that much talked about incretin defect, which is also an important pathognomonic feature of type 2 diabetes. And that is why when we talk about unmet needs with complex regimen in type 2 diabetes, this evolution of many glucose lowering therapies, glycemic control, we never reach that tight control in many of our patients. The complex insulin regimens like multiple injections, which could also associated with reduction in flexibility, increased chance of hypoglycemia and weight gain. And there are certain factors impacting the potential treatment burden of complex treatment regimens like lifestyle, multiple daily injections, especially when we talk about basal bolus therapy, even in premix insulin, the diet and physical activity. So for that, the combination injectables are always preferred. Why? Because we taught about therapeutic parsimony. So something which could increase the adherence to therapy. So if we talk about two titrable drugs, one could be basal insulin and another is GLP-1 combined in a single injection, which could be considered as a combination injectable. Here we are talking about glargine U100 and lixisenatide, Iglar-Lixi, which is very few months it is approved in India. And I think though this talk, I don't have any disclaimer for this particular talk, but as this topic is going to be discussed around that basal insulin and GLP-1 we need to take example of Iglar-Lixi. And as we talk about Iglar-Lixi, which could be an representative of that broad class where we want to understand the combination of basal insulin and GLP-1, this actually targets almost 7 of those ominous octet of type 2 diabetes. Insulin will take care of hepatic glucose production and gluconeogenesis, glucose uptake in muscles and lipolysis, whereas GLP-1 will take care of glucose-dependent insulin release increment, decreasing the glucose-dependent glucagon release, increasing satiety and decreasing gastric emptying. And when we talk about potential benefit of combination injectable, there are multiple evidence-based results in terms of effective HbA1c reduction, both fasting and PP control, fasting with basal insulin part, PP with short-acting GLP-1 addressing multiple pathophysiological defects as discussed just now, more people achieving glycemic targets, once-a-day dosing, therapeutic parsimony, weight benefit, or rather neutrality, because if we use only insulin, it will cause some weight gain. But as we are mixing one GLP-1 even if it is a short-acting GLP-1 that is going to cause some weight neutrality. So lower rates of or very less risk of hypoglycemia and improved GI tolerability versus monocomponent because we are starting slow. So if we need only GLP-1 so we need to reach the maximum dose, and that may be associated with more GI symptoms. And that is the beauty. If I am having a basal insulin with us, so that is going to cause less requirement of dose of GLP-1 which ultimately reduce the overall gastric intolerance. So that is why all global guidelines recommending the combination injectable, starting from ADA 2024, even 2025 to ACE and ADA-EST, all are having one consensus that combination of basal insulin with GLP-1 that will has number one, the greater efficacy, number two, less weight gain and lower rate of hypoglycemia, and number three, better gastrointestinal tolerability. So this 3 point favors this combination injectable. Due to paucity of time, I think these all evidences are not required, but I shall sum up whatever clinical trial evidences we have with this particular molecule, that is glargine and lixisenatide. We can see loads of informations that are already available in net. I am not going in details of the study designs. One thing I want to highlight, because all these studies had shown the weight benefit compared to even the IDEG-ASP, which has digludac and aspart. The SOLID study had clear-cut shown even with Iglar-Lixi, there is a reduction in 7-point SMBG values. And overall insulin dose requirement was much lesser, including the nocturnal hypoglycemia, event rate of total hypoglycemia was much lesser. So to summarize the SOLID study, which is a 24 weeks head-to-head study conducted in Chinese type 2 diabetes patients who are also like us, a high carbohydrate eater. They are suboptimally controlled on OADs. So Iglar-Lixi has demonstrated versus IDEG-ASP non-inferiority and statistical superiority in HbA1c reduction, superior body weight benefit, more patients achieve those composite endpoints, lower risk of hypoglycemic events, and no unexpected safety benefits. So this is a valuable option providing overall efficiency of type 2 diabetes therapy. Now, Lixilan-O, which is also a confirmatory study that why this combination is superior than only basal lantus or glargine U100 or only lixisenatide. So this is another important study when we have some questions in our mind whether we should start a premix analog or this combination injectable basal plus GLP-1, Iglar-Lixi or not. Again, in this particular study, there are almost 180 Indian patients had been included. And that study had shown Iglar-Lixi arm has superior HbA1c reduction weight benefit versus bias 30. And apart from that, the target achievement was significantly greater in the Iglar-Lixi arm with less insulin daily dose requirement. The hypoglycemia, again, the safety issues, there is lower risk of hypoglycemia in the Iglar-Lixi arm compared to bias 30. So efficacy-wise, Iglar-Lixi was better. It was efficacious, simpler, and safety-wise, they were well tolerated in both the group with less hypoglycemia in the Iglar-Lixi arm. This is for an example how Iglar-Lixi is important, especially this is the pain, the 10 to 40 unit pain, maximum 40 unit we can give. We should start low and go slow, and then gradually we need to up titrate the dose. So in the lixisenatide and glargine, the ratio, the glargine is to lixisenatide was 2 unit is to 1 microgram in that pain. So according to that, we need to start with 10 unit. If I am starting in insulin naive patient on OAD, if patient is already on insulin glargine less than 20 unit, then also we need to start with 10 unit. If the insulin glargine dose is more than 20 unit, we should start with at 20 unit of Lixilan. Here we need to understand, especially if we start with 20 unit of Iglar-Lixi, we need to educate our patient regarding the GI adverse effect. So this could be an easier way, just like what we had done with insulin, we can up titrate or down titrate the dose of Igler-Lixi. If it is between 100 to 140 plus 2, 80 to 100, no change of dose. If less than 80, minus 2. And if it is more than 140, fasting self-monitoring plasma glucose, then we need to add plus 4. So the most important point, Igler-Lixi should be injected subcutaneously once a day within 1 hour prior to meal. So between 1 hour to 15 minutes we can give, not that much more than 1 hour. But very important, Dr. Alok Modi had beautifully described how we enjoy flexibility while we are using Glargine U300 or Digludac. But here, if time should be same per day, because we are using Glargine U100 here. So there should not be change in the time. So preferable than the prandial injection is performed before the same meal every day. Same meal, and that meal preferably to be taken at the same time. So if there is any missed dose, it should be injected within the hour prior to the next meal. So weekly dose adjustment should be done. Usage in special population, elderly population, there is a good data on elderly patients whose age is more than 65. It can be used in patients who have mild or moderate renal impairment, but as lixisenatide is not recommended for those patients who have severe renal impairment, especially eGFR less than 30, we should not use in that population. Hepatic impaired case we can use in patients with hepatic impaired, but need to be cautious, especially when I am seeing childbirth C-score patient. But for pregnancy, Igler-Lixi should not be used. So to summarize, when we talk about Igler-Lixi, though it is not synergistic in terms of regulatory signs, but it has multiple synergistic role, pharmacodynamic role, once daily combination, and most importantly, it has effective control on fasting and postprandial glycemia, hyperglycemia. We have good, well-designed RCTs, SOLID trial, which indicates Igler-Lixi is a simple, well-tolerated treatment that has shown better glycemic control with added body weight benefit and low risk of hypoglycemia events compared to Idegas. And if we talk about Solimix trial, then also we can understand Igler-Lixi as an efficacious, simpler, well-tolerated, provided better glycemic control with weight benefit and less hypoglycemia. And the comparator was by us 30. So once again, I want to thank Dr. Bharat Sabu for giving me this opportunity to share my thoughts in front of this August gathering. Thank you.
Thank you, Dr. Shambo. This is really a very interesting talk, and only you can handle this so beautifully. Just a quick question, because this is the new kid in the block and everyone is talking about these days. What is the best patient profile you think is most suitable for this type of combination molecule like Igler-Lixi?
Yeah. So again, if there is the fasting PP gap, what we understand, the postprandial glycemic excursion, if it is high, maybe more than 40. So we need to think about this molecule, especially when we are taking some treatment naive patient who are on multiple OADs, especially 3 or more OADs, and HbA1c is not under control. We are planning to start basal insulin. I think it could be a good option when there is body weight a critical factor. So there also we can use this molecule. I think this is an important molecule for us, and all our type 2 diabetes patient, most of our type 2 diabetes patient should also have the dog catchers, that glucagon dog catchers, what we had mentioned, because the hyperglucagonemia need to be controlled in most of our type 2 diabetes patient. And for that, I think this molecule, this combination will be really beneficial.
Wonderful. So, with
There-
yeah, please go ahead.
Yeah, of course, there are certain specific contraindications, especially we know about the pancreatitis issues, though there are counter arguments too, but already if the patient has a history of pancreatitis, we need to avoid. And if there is some family history of thyroid carcinoma, especially the MTC, we need to be very much cautious and better not to use.
Wonderful, Shambu. Due to paucity of time, just a quick comment from both Dr. Sandeep and Dr. Alok, sir.
The Lexi-Lang combination. Audible? Yes. So
Yes, sir.
issue is that we were having premix insulin. We have got co-formulation. So issue was two. One was hypoglycemia. Another was weight gain. So now we combine this molecule, lexisenatide, which is a short-acting GLP-1 receptor analog, along with long-acting insulin. So here gives you the benefit of decreasing postprandial hyperglycemia very well. Plus, it will give you benefit of lesser chances of developing hypo and also decreasing the dose of insulin. And second thing is that weight loss will be there. So you can get the benefit of GLP-1 and also benefit of long-acting insulin, controlling your fasting hyperglycemia, interprandial hyperglycemia, and postprandial hyperglycemia will be taken care by lexisenatide. But issue is that it's a short-acting molecule. When you are going to start this molecule, it has to be timely initiation. You cannot delay it that later on when there is nothing left in your beta cell, you are going to try with this molecule. This is absolutely failure. Absolute failure. You cannot give it a BD dose. So you have to be exactly looking at OAD inadequacy, not looking for OAD failure. So once your three drugs are not working and you have got one meal which is giving you highest postprandial spike, fasting somewhat high, not much difference between fasting and postprandial because it is not an insulin. It is insulin is much more potent glycemia management tool in comparison to glargine, whatever the in comparison to GLP-1 receptor analog, whatever the data is. GLP-1 data is basically having additional benefit over and above their glycemia reduction. So we are looking for weight loss, we are looking for other factors. So if you want to try this molecule only when you are in a timely way. Hello.
Hello.
Yes. I think I was audible or disconnected.
You were audible, sir, but with little patches in between. But you were very much audible and the message was very clear. Alok bhai, just a quick comment from you.
I totally agree. Actually, sir has covered it very nicely. I have a little different practical take on where I use it. So today we are treating obesity, so we have diabetes. So I always have that itch to start a GLP. And little mitral walking and little retinal walking in 3 to 4 years. So I find this is the best drug where I can give best of both the worlds to these patients straight away. I don't look at other parameters. I just look at a little organ damage because that is what we are interested in. Little endothelial atherosclerotic organ damage and a little obesity. And I encourage my patients to go on that and I get fantastic results. The journey in future is I don't look at 2 sulfonylureas, 3 sulfonylureas or 4 orals or whatever. I started very early. I can probably just give this with only metformin and I get good results. But I sort of pressurize my patients to go on this with a little obesity and a little of early organ damage, a little high EGFR, a little micral 70 or something, a little this, and I start. And I have patients following up after 3 years or I think 2.5 years or 2 years, I'm not sure, but I'm getting very good results.
Wonderful, Alok bhai.
Very practical take. I mean, that has covered everything. It's just another practical take to this molecule.
So Alok bhai has actually set the agenda for the next talk because this talk is actually talking about the practical aspects where patient-centric approaches, what are they in insulin and GLP-1 practices. He's a very good friend of mine. He is the president of IP Haryana chapter. He has done fellowship in diabetes management from CMC and fellowship in diabetic foot management also. He is a fellow of Diabetes India and RSSDI, recipient of gold medal at CMC Vellore, recipient of award for excellence in diabetes care at RSSDI 2019. He is life member of various societies, a speaker par excellence, as he has various publications and book chapters. So he will be making it simpler for us. What are the practical aspects about all these things?
Let me share my screen.
Yeah,
So
sir,
once
please.
again, good evening, friends. And I think most of my talk has been covered by Dr. Alok, Dr. Manthan, and Dr. Shambhu. They have all covered it. So I don't have anything more to share, but just giving you an overview and my thoughts on the topic, the patient centricity and for approaches for insulin and GLP-1 receptor analog. So slides visible?
Yes, sir. Just make
Okay.
it full screen.
So,
Thank you.
yes.
Thank you.
So we all agree that insulin and GLP-1 receptor analogs, these are the two injectable molecules. And yes, we do have oral GLP-1 receptor analog in the form of semaglutide with us. But practically speaking, insulin and GLP-1 receptor analog, these are the two injectable therapies. And we all know that these are the two most potent glucose lowering agents. And we also know that the India is particularly having double whammy, or we can say that triple trouble, or you can say multiple trouble related to diabetes. If you talk about numbers, they are increasing. If you talk about undiagnosed diabetes, again, it is more than 50%. If you talk about uncontrolled diabetes, we are just managing up to 30% of patients having HbA1c less than 7%. If you talk about complicated diabetes, right at the beginning, 20 to 30% patients, type 2 diabetic patient, right at the time of diagnosis, they have got micro and macro cell complication. So it's a burden, it's a burden, big burden on our healthcare infrastructure. And it's a big trouble for all of us particularly looking for the management of diabetes. And we all know, doing everything, so many societies, so many CMEs, HbA1c is still lingering on above 8.5%, the Indian data says. And two molecules, insulin and GLP-1 receptor analog, which are the most potent molecules, they are injectable. And once we talk about individualized, personalized, and tailor-made therapy, and you talk about these injectable, patient is not going to agree. And there are so many myths and so many phobias in patient's mind, and more, not only in patient's mind, it's in our mind. Psychological insulin resistance lies here. So it's in our mind that we are not talking about insulin. And if you see the data says you have to talk about insulin even in the initial phase of type 2 diabetes, when patient will not be requiring insulin, but you have to prime them. So what we are doing, we are talking about insulin 10, 15, 20 years later on. So if you talk about insulin, everything is very much clear to all of us. We have got rapid acting insulin analog, we have got long acting insulin analog, we have got various permutation and combination with us. But the major channel, timely insulin initiation. And also we are getting more physiological insulin. More physiological, not exactly, but more physiological rapid acting analog, more physiological long acting analog, and lot many window periods are there. You can have window period of 6 hours, you can have a window period of 40 hours. So it's an 8 to 40 hours window period, depending upon the long acting analog which you are using. You have got window period of 15 minutes, window period of 20 minutes in between the meal, just after meal. So it is becoming more tailor-made therapy. But to initiate insulin is a big factor. Similarly, GLP-1 receptor analog, we have moved away from shorter acting molecule to longer and longer acting molecule. Once weekly is there. Maybe you can have 6 monthly. You can have device which can be put into subcutaneous space, and that device can give you 6 monthly GLP-1 receptor analog. And we have got all virtues of GLP-1 receptor analog. But issue is that we have to initiate them in a timely way, not keep on putting everything which is there in your pharmacy into your prescription. So that clinical inertia and therapeutic inertia should go away. So it's a really very important time that we must look at patient-centric approach, repeatedly looking at the window period of opportunity that starts right from 3 months after the initial diagnosis of diabetes, then 6 months, then 1 year. So this 1 year, you have to reach to the target, and then you have to maintain the target of less than 7% or up to 6.5%. And if you are able to manage, keep it just below 6.5 without causing any hypoglycemia. So that should be a dictum, proactive approach. And why we should not use insulin and GLP-1 receptor analog in a proactive way? So we all know, everybody, if you talk about insulin, GLP-1, they will always say, yes, sir, we know everything. But how to initiate? When we talk about insulin, we know everything about GLP-1. We know about CVOTs of GLP-1, not many pleiotropic benefit, 3-point MACE benefit, weight reduction is there, renal benefits are there. Similarly, you can see the weight loss with all CVOT, everything is in favor of GLP-1 receptor analog, era of GLP-1 receptor analog, but there are a lot of challenges and lot of barriers. But there are barriers in management of diabetes in Indian patients. We have got diet as a big issue. 65%, 70% calories coming from high carb. We are carb-loving people, high PPG, patient uncontrolled on multiple oral anti-diabetic drugs, and we do need simplicity and convenience. So there is a lot of treatment delays and barriers. And if you look at this study, DAWN study, diabetes attitude, wishes, and needs, 48% of patients initiating insulin believed they had failed to manage their diabetes correctly. This is the very important practical aspect. Patient feels कि डॉक्टर साहब मेरा डायबिटीज इतना खराब हो गया कि मुझे आप इंसुलिन पूछ रहे हो, मुझे आप इंसुलिन के लिए बोल रहे हो. It's a very patient sitting in front of you innocently, and he's just looking at your face that he's asking for you are asking for insulin, and I'm nothing to have. My days are over. 52% are worried about initiating insulin. Once they come into my chamber, I am into certain setup in a certain status that patient thinks that if you go there, he will start insulin because he knows that your HbA1c is above 9.5, you are not able to manage with 3, 4, 5 drugs, and there is no way. If you go inside, he will start insulin. So 52% are just worried about initiating insulin. Only 23% believed insulin could help manage their diabetes. So you have to talk about 70 to 75% of the patients who are not willing to start insulin. And if this is not the scenario in India, in Asia, it's a 60%, or overall, if you say, whole globe, the acceptance of insulin and injectable therapy is dismal. And those patients who start insulin, they just don't adhere to the insulin therapy. So percentage of patients who do not progress in insulin treatment, it is not initiation. You have to optimize the therapy. You have to intensify the therapy also. So all these 3 steps, they have certain sort of inertia. And that happens to more than 60 to 70% of your cases. So what are the barriers to insulin usage? Hour related, that means healthcare physician related. We are worried about adverse effect of insulin. Insulin can cause hypo. Friends, hypo is basically an educational issue. You have to educate your patient. You have to train your patient. The drug is tuned to decrease blood sugar. Obviously, it will overshoot. It can lead to hypoglycemia. So you have to talk about hypoglycemia. Rigid scheduling. We have got different type of insulins now. You can just be a good magician and you can make a tailor-made shirt according to a fitting to the patient size. Patient non-compliance, we will think that patient will be non-compliant to insulin. No, absolutely no. Everybody wants to be a healthy life. So you have to be more, spend time with the patient to tell about the insulin, the benefits of insulin. Lack of time per patient. Yes, we are always under some sort of pressure cooker situation. But friends, the patients who require insulin, you can have 20, 10 or 15 patients out of your 100, they will be requiring insulin. So there you have to spend time, and that time you can make your own team, diabetes educator team. Even if I'm not boasting, but even the gatekeeper, even my sweeper, even my hospital staff who is not dealing with day-to-day giving therapy or giving treatment to the patient, they are just trained as a diabetes educator. You have to train them, you have to teach them about insulin, how to convince about insulin, because your patient will be very well maybe more feel more easy to talk to other person, not in front of you. Maybe some other person can talk with them in their own language. and they can definitely convince. And have your insulin coaches with you, the patient and your OPD. And in your OPD, 20 or 30% patient may be on insulin. Some type 1 child can be there, and they can tell your patient, those who you are thinking that you should put on insulin, they can tell that patient, yes, I am on insulin for 6 years, I am on insulin for 10 years, I am on insulin for 5 years, and I have got no problem. My life is important. My life is, it makes my life absolutely changed, and my management is absolutely changed. These are my reports. So if these are the people who are the insulin coaches, who are insulin heroes in front of you, make use of them. So, and for patient, forgetfulness or a cautious decision can be there. Physical pain, you can just give one injection in front of you, show them the needles. They are absolutely hair fine needles, 4 mm size needle. Hardly they are visible by naked eyes. Ease of use, very convenient. Pen devices are there. Psychological embarrassment can be there. Yes, patient can think of that, but you can convince your patient, sit with the patient, address everything, every issue which is there. It needs time, but hardly it takes more than 10 minutes. So 10 minutes proper, but don't, here I give you one more point. Don't leave your patient to your only diabetes educator, because patient wants your uh, your words and your pat on his or her shoulder. So don't leave to the staff कि ये इंसुलिन सीखना है तो आप कमरा नंबर 3 में चले जाइए. नो, इंसुलिन के बारे में बात करना है तो गो टू कमरा नंबर 5. नो, not like that. He or she has come to you. You are the best person who can manage this patient, who can listen to him or her, and they require your 5 to 10 minutes. And you have to go away from all myths and misconceptions of patient's mind. So technologies have definitely changed, but I think it is more of psychological issue that you have to talk about. Technology will make the things like less painful injection in the form of pens, needles, devices, improved compliance to the regimens, fewer hypoglycemic episodes, more well monitoring. You can have CGMS data, you can have SMBG data that can put to apps, and you can get the whole picture. Better glycemic control is there. Absolute good patient satisfaction and good improvement in quality of life. Definitely cost savings. So cost technology is definitely there, but the patient requires your conviction. He's looking at your face, and so it's a more of psychological part. So technology cannot give you that thing. That acceptance can be improved, but first cue has to be from your side. Like pens has make things easier. Shorter needles are just painless, and you have got various type of technologies which can be connected to you, and the patient can get the real data, and also the doctor can get the real data also, and patient knows how much injection he has given, how much dose he has given, or right dose has been given or not. So everything is there, but there are certain important practical tips. Sit with the patient, assess and appraise the misinformation. So most of the time, it's the misinformation which is there, which is the key barrier in patient's mind. Specific fears like hypo, painful needles, or patient has got certain concerns about the organ dysfunction related to insulin. Appreciate that patient's concern. Don't just say ऐसा कुछ नहीं होता है, आपको गलत सुना है, ये गलत छपा है, गलत बोलते हैं. Not like that. Appreciate patient's concern. Always be empathetic. This again very important word Dr. Shambo was saying again and again. Empathy is extremely important, which AI cannot give. So I am definitely, this is the place which requires human touch. So empathy, educate your patient, empower your patient, and explain everything related to insulin, why you are giving insulin, what can be the benefits of insulin. Be a good salesman. It's very important. Dr. Bharat Sabu went for a trouser purchase. He came back after having trouser plus 2 shirts also. So he encountered a very good salesperson. And he said, oh, Dr. Saab, you are here. Why I am giving you such a cheaper trouser, you can get 2 more shirts again. You will look so smart, so fine. Next conference at Ahmedabad, why not to have this shirt? So he came back with the 2 shirts plus 1 trouser. So be a good salesman. So it's very, very important to inform correct scientific facts to the patient. Impress regarding benefits of insulin. Tell them the positive effect of insulin, improvement in quality of life that you will get with the insulin before even you get the glycemic control. And then injection techniques are extremely important. So you have to offer education, counseling, and support to the patient, and then keep on upgrading the knowledge of the patient. Self-care capability, only then patient will be able to do SMBG, reporting everything to you, and always make a information equipoise. I always ask my patient, अपने staff को यही कहता हूँ कि इस ढंग से उनको पढ़ाओ, इस ढंग से समझाओ कि उनकी knowledge और आपकी knowledge के बीच में equipoise हो जाए. That means absolutely same, आप एक ही level पे हो जाओ. So this is how you have to convince your patient. You can give 1 injection in front of you and tell them the positivity. Tell them the positivity, which is the maximum. The effect is patient remains in a misconception. So this is again important aspect of insulin stewardship, that you have to know about the insulin initiation, monitoring, safety, everything. Various things are. So coming to the summary and conclusion, remember, we have moved from glucocentricity to complication centricity and pathogenic centricity. But patient centricity is the key factor. So it has to be tailor-made, and don't delay insulinization, and don't delay GLP-1 receptor analog whenever you think that these are the molecules to be required for management of this patient. So here comes one more important thing. Please don't worry about leaving your patient. Please don't worry. There are 6 stages, those Kaksha stages of psychology. There are 6 stages. One stage is that patient will say, I will not take insulin. चाहे कुछ हो जाए, चाहे मर जाऊं, insulin नहीं लूंगा. So that clearly indicate patient is not being told, or patient is just unaware about the situation. That means he's thinking कि glycemic control, मेरा sugar control हो ना हो, मुझे कोई लेना देना नहीं है, जो होगा देखा जाएगा, कुछ भी हो जाए, मैं insulin नहीं लूंगा. So that patient is just, I will not take insulin. So this patient is unaware about the situation. You have to make him aware that this is the situation. If you don't take it now, it will keep on lingering on, and you will have many problems. So make him aware. So I will not get it converted to I shall not. Now I will not to get I shall not means that why I should take insulin, but why I should take insulin. So why not other molecule? Why not other SUs? You have got so many, you have got such a big name. Give me another molecule. Why should I go to insulin? But that means he is coming to stage 2. Stage 2 is contemplation. And stage 3 is again, I cannot take insulin. That means I am convinced about insulin. I know my situation, but I cannot. I am not capable of taking insulin. My lifestyle is very different. My work life is very different. I have to travel a lot. My duties are there. I don't have any caregiver at my home. There is no help available to me. Who will give injection? Who will give injection to me? So that is again a stage 2. That is contemplation stage. So initial pre-contemplation stage was there when he was not I will not take. Then I shall not take. Then I cannot take. So they are coming down. The patient is coming down. But slowly, within 10 minutes, patient will be convinced by all talking to you, and you give him the technique of easy insulin initiation in front of you, and patient accepts. Then comes stage 3. And this stage is action that leads to little changes. Comes back to you after 7 days, 10 days. Yes, I'm feeling somewhat okay, fine. My blood sugars are coming down and I'm feeling much better. So that is stage 3. Now then comes stage 4. That is regularly he or she is taking insulin, getting SMBG reports to you, getting results also, and you are feeling smile on patient's face. And that is the thing that now stage 5 will come. Patient will tries to maintain good level. I cannot go, 150 nahi aana chahiye, make it 140. I will try to change insulin dose. and also I will try to change my lifestyle. डॉक्टर साहब हमारी डाइट थोड़ा और improve करो ना, इसको कम करेंगे. This is the way. This is the way. And then comes stage 6. Patient doesn't want to change insulin, doesn't want to leave insulin. मेरे को इसी पे रखना है. Okay, so this is this, and then again patient comes in. Patient comes coming in contact with Dr. Alok Modi, Dr. Bharat Saab, who says, Dr. Saab, they are going for time in range. You are not talking about time in range. So he will come to you, put me on AGP. Let's control it much more better. So this is stage 6. Now, how much time it goes take to stage from stage 1 to stage 6? It will take day 1 to day 6 months. So 6 months, you are able to achieve better compliance of the patient, adherence of the patient, intensification has been done, optimization has been done, and this patient is rightly on insulinization. So friends, if you take all these aspects and the other fulcrum, don't make it a punishment. Don't make a sort ki I am such big diabetologist and patient is not talking, patient not accepting my command. So it's not the way. It's not the way, and don't make it a punishment. So if you do like this, patient will definitely run away from you. So don't do it like this. So be patient and empathetically take things into your hand. It is more of psychology you have to play with. So friend, insulin initiation is an art, and science, it's a definite blend. So this is how I talk about insulin initiation. Thank you.
Thank you, Sandeep sir, for this really enlightening talk. I have never seen such a beautiful talk on patient-centricness on diabetes. Although the talks were very crisp, we overshot our time by a huge 23 minutes, but it was indeed memorable, and we still see people around with us. But in paucity of time, because I think we need to wind up, I will just like to take one quick take-home message from all of our faculties, starting from Dr. Manthan Sheth. Dr. Manthan. Dr. Manthan, you are muted.
Sorry for bringing that to my notice that I was mute. Sorry. Yeah. So I would like to say that being a diabetologist and physician, we have that one very thin line, and that separates us by giving an ample of time to our patients, as well as having empathy towards them. That is the biggest things, and that should be done from our end. As Sandeep Suri sir has rightly told me, that rightly told to all of us, right, that it should not be that someone should go to so and so room number. It should be we that should be doing that aspect, right? And I would definitely remember one of my diabetes guru who told me that, Manthan, either you take the lesser number of appointments, but give at least 30 to 40 minutes of the time, then you will be following my footsteps, that you are on the right track. So I would say that it's sometimes a little bit hard when you have a busy OPD, but definitely we should give some sort of a good ample of time, at least 30 minutes, when we have the new patients with us, and we have to be very empathetic. So I would say the take-home message is the empathy is everything to initiate the insulin for our patients.
Thank you. Thank you, Dr. Manthan. Dr. Alok sir, just a quick take-home.
No. I just want to say one thing here. I find this works very well. Whenever a patient comes, I let him talk. I let his mother-in-law talk. I let his wife talk, or the spouse if the patient is a lady. I let them pour out their heart, and they come out with a lot of knowledge, which is you feel like laughing or crying. But I let them talk and I nod my head. I don't say yes, I nod my head. They feel yes, I'm agreeing with them. I just give a little parting message. Just say you said one word from all the speaker. I give them one small sentence to shake them a little bit, but I agree. Yes, what you're saying is right. You have 20 years of experience with diabetes. Who am I to teach you anything? It takes me. The problem is, we are hardcore clinicians. We are highly connected with our patients. We want to do the best in one clinic. We are enthusiastic. We want to do the best for our patients. So it's a very good feeling that we have. But in the bargain, the patient doesn't understand our goodwill. So I let them push on and on, on and on. जब उनका mentality change होता है, and I've seen more than that. Medical store वाला उसको कैसे influence करता है, उसके फैमिली डॉक्टर उनसे क्या बात करते हैं, and what does his family member say, his mother-in-law, father-in-law, neighbors. Once they, what's important to talk with I like to call them with their family and their friends. I talk with them rather than the patient. Once they come online, फिर things become very loyal and very smooth. Some practical tips, I'm sorry to say, this is what I follow.
Thank you, Alok bhai. Thank you. We are really short of time. We will come back to this some other day because we know you have such huge experience. You can talk on for hours on this. Sandeep sir, a quick
Yes,
take
only
home.
thing,
from
one
your
line
end.
that
Although your
yes,
whole
yes,
talk
yes,
was take home, but a
yes,
quick
yes,
take home from
yes.
you.
Only thing that it's a treatment of diabetes by ears. So treat diabetes by ears. So listen to your patient. It's very, very important. He is telling you everything, everything. So art of medicine is listening to the patient. So sit with the patient, give comfortable 5 to 7 minutes, look into eyes of the patient, face of the patient. Don't look at your laptop or any screen or your mobile. Don't do at that time, because this is very serious issue and the patient has to be on insulin for maybe lifelong. So it's a really very, very important. And he's remembering the pain of the injection right from the tetanus, right from the vaccination time. नश्तर जब लगा था उसको तब से उसको याद है. So that you have to think that you cannot ignore those feelings. And but yes, the patient requires insulin and you are the best person to give him the treatment and manage this patient.
Thank you. So with that, I thank all the faculties, starting from Dr. Manthan Sheth to Dr. Alok Modi, to Dr. Shambo Samraat, to Dr. Sandeep Suri for enlightening our audience with this knowledge, because it is very rare to find these gems together talking so beautifully on one single aspect, that is injectable therapies in and around diabetes. In the end, I would like to thank our partners, Cipla and Walron Pharma, also for bringing this to our notice that something like this can be done. And in the end, a huge thank to the audience, around 242 odd people who have joined today for all these things. Thank you. The recording will be we will be sharing soon after editing to everyone.
One second, Bharat bhai, just one quick sentence. We would like to thank, and I'm sure others would like to thank you, Dr. Bharat Sabu, for conducting it so beautifully and arranging the whole thing.
Absolutely.
And the director and the producer and the actor behind the scene, not speaking a single word. We would have loved to listen to your
movie
wonderful
runs
talk.
with Allu Arjun, not with director, sir. So you are Allu Arjun for us.
Thank you. But
Good night, everyone.
Thank you very much for
Good
the
night.
kind
Thank
invitation.
you so much, Bharat bhai. Thank you so much,
thanks to
everyone.
you.
Thank you.